and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. We at IHW Council believe that health is the most fundamental aspect of human existence, prosperity, and happiness. And we work towards creating a better and healthy world for all through various initiatives and endeavors. I welcome all of you to this Kidney Care Summit 2024, an IHW Council initiative powered by RG Hospitals. Kidney health is an important aspect of overall health and well-being of individuals. The global burden of chronic kidney disease, or CKD as it is called, is rapidly increasing, with a projection of becoming the fifth most common cause of years of life lost globally by the year 2040. Currently, around 850 million people are affected by different types of kidney disorders annually. Up to 1 in 10 adults worldwide has chronic kidney disease, CKD, which is invariably irreversible and mostly progressive. India, that is the home to one of the largest number of NCD patients with nearly 5.8 million deaths annually, has substantial burden of kidney ailments that are triggered by conditions like diabetes, hypertension, and obesity, among many others. Studies have also estimated that the number of new patients diagnosed with end-stage kidney disease in India is over 1 lakh per year. Chronic kidney disease has become a major cause of catastrophic health expenditure. The cost of dialysis and transplantation consumes up to 3% of the annual healthcare budget in high-income countries. Therefore, strengthening the healthcare system for prevention and creating a supportive environment for chronic kidney patients and their caregivers is imperative. And this makes this year's international theme of kidney health for all, advancing equitable access to care and optimal medication practice, all the more relevant and critical. So with this firm resolve to advance kidney health as an essential component of comprehensive healthcare and initiate health equity so that kidney care is accessible and affordable and leaves no one behind, let's commence the opening session of today's summit. And we have a galaxy of very eminent doctors, experts, and also policymakers in this session. So let me welcome Dr. Dinesh Khullar, Chairman of Nephrology and Renal Transplant Medicine at Max Super Specialty Hospital in New Delhi. We have Dr. Syam Bihari Bansal, Director and Head Department of Nephrology and Renal Transplant in Medanta, the Medicity, Gurugram. We are also joined with Dr. Narayan Prasad, Professor, Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, and Dr. Himanshu Sekhar Mahapatra, who is HOD and Professor of Nephrology Department at Ram Manohar Lohia Hospital in New Delhi. And last but not the least, we have Dr. Urvashi Prasad with us. She is the Director at the Office of Vice Chairman at Niti Aayog, which is the apex, policy-making body of the Government of India. So welcome all of you for this Kidney Care Summit. And so let me begin with Dr. Khullar to set the context first. Dr. Khullar, though I mentioned some of the numbers in terms of the chronic kidney disease prevalence in India as well as the world, from your point of view, what are the prevalence which you see, and what are the major risk factors which are kind of contributing to this prevalence and actually making the burden higher?
Well, at the outset, my sincere thanks to you, Mr. Kamal, for this wonderful opportunity. And I think this is very, very relevant in today's context. And you rightly pointed out the enormity of the task we have in front of us, the gravity of the situation which means that, and to take it a little further, it's generally estimated that about 10 to 16% of the Indian population has some kind of chronic kidney disease. Now, even if we go by the conservative figures of 10%, look at what we are talking about. 140 crore population, out of which about 10% have some degree of chronic kidney disease, about close to 14 crores. And the problem is, this is chronic kidney disease. And the meaning of it is, it's a progressive disease. It's not going to stop anywhere. It takes a relentless course and gradually and insidiously keeps on increasing. That's one aspect. Now, we also know that in India, we have the largest number of diabetics. Now, look at where we are. Again, close to about 10 crore of Indian population is generally estimated to be having diabetes. Now, and we know kidney disease is one of the favorites of diabetes, I would say, which means that about 40%, the number could be anywhere between, I would say, 1/3 to 2/3 of diabetics getting some kind of kidney disease. Even if we now again put it a conservative figure of 40%, look at what we are talking about. 4 crore of Indian population has something called diabetic kidney disease. This again is progressive. The problem is, on one hand, we are taking pride in the fact that India as a country is doing very well. Now, we are not wanting to waste all the resources to things like non-communicable diseases, especially chronic kidney disease, of which diabetes, high blood pressure form the big chunk. So to answer your question one more time as to what you said about asking me, what are the common causes? Well, beyond doubt, these are diabetes, high blood pressure, lifestyle diseases, obesity, smoking, whole lot of things. But look at the staggering figures. Now, this could mean almost like many countries put together, the kind of patients suffering from chronic kidney disease is concerned, as far as India's contribution is concerned.
Thank you, Dr. Khullar. So important facts which you have put forward, and obviously the number look extremely staggering in the terms of the kind of challenge we have when we see at the kidney diseases prevalence in our country. Let me go to Dr. Bansal and get a little bit more on it. Dr. Bansal, as Dr. Khullar said, that around 10%, 10 to 16% Indians are expected to have some kind of kidney ailments. Diabetes is another, the big number, which directly maybe up to 40% on a conservative estimation, lead to, diabetes, kidney-related problems. If we talk about, let's say, chronic kidney diseases, this number, how much, kind of further funnel down in terms of people who have the chronic problem in the, which is, damaged kidney and which is progressive as in most of the cases. And how much of it actually leads to the requirement of dialysis or maybe transplant? So how you see this funnel going down to more specific interventions?
So there are two problems. Actually, one is the how many have chronic kidney disease. So one, we are talking about the public awareness. So this is a very important. 50% of the people are actually aware that they have kidney disease. So, and there is some time back, there was a study was conducted, which is the screening and early evaluation of kidney disease, a SEEK study in India, and which quantified that approximately 17% of the people, they have chronic kidney disease. But of those,
20% of the entire population.
Screening population. But most of them, they had early stages of the kidney disease. If we see stage 4, 5, so approximately more, and even 1 to 2% in the stage 5. We see the other way around, the diagnosis of the kidney disease. But if we see the people who are actually diagnosed as CKD, 50% of them are diagnosed in India at stage 5 CKD, stage 4 or 5 CKD. So the early detection is lacking. If you talk in terms of number, approximately 2 to 2.5 lakh of patients, they develop kidney failure each year. So that is the the number. And now with increasing availability of dialysis because of the government support of the dialysis in many centers, in the government hospitals and other private and public partnership models, the number of dialysis centers have gone up. Maybe you add 50 to 60,000 patients per year in the dialysis, but still a lot of patients actually they are not able to either get the dialysis or these treatment or afford the treatment even after so much support from the government. So it is more important that we keep the public, we aware the public about this enormity of the problem so that they can do their preventive checkup, take care of their diabetes, hypertension, and either prevent or at least slow down. So the other thing is that even after the diagnosis, less than 50% of the and they get the appropriate treatment, which significantly slows the progression of kidney disease. But if you see the actual people who are utilizing all these therapies still, so there's a need to create awareness among the care provider, among the nephrologists also, that you use these therapies that actually help in the slowing the progression of these diseases.
Thank you so much, Dr. Bansal, though there was still some, kind of disturbance in getting your voice, but we could make out a few important fact out of it, and especially the one where you are talking about that, which is little startling as well, that around 50% of the CKD, is diagnosed at the stage 5. Red is at one of the finest center for nephrology in the country at the Sanjay Gandhi Institute in Lucknow. Dr. Narayan, and especially I also want to understand a little bit of demographic or geographic distribution of this disease. And if I look at, while we had Dr. Khullar, Dr. Bansal, sitting in the heart of our country in Delhi, which wish to get the patient from across the country, but your hospital gets a lot of patients coming from the rural areas also. So, and I would also request to, in the portions where we could not hear Dr. Bansal clearly, if you may like to touch upon those points as well. So again, Dr. Narayan, what is the burden we are seeing when it comes to rural area as well? How many patients, or what is the ratio of the patients which are coming at a very advanced stage? Obviously, not being able to pick up or screen or diagnose the disease in earlier stages, and the other point which Dr. Bansal mentioned, that a lot of patients are still not able to get the dialysis kind of support, which is being extensively ramped up by the government as well. So what is your take on these areas and these aspects, Dr. Narayan?
Yeah, first of all, a lot of thanks to you for taking this important topic a day before World Kidney Day is going to be celebrated tomorrow worldwide. And the purpose of all that World Kidney Day is to make awareness. And the dream of this International Society of Nephrology is there that the kidney health for all and equitable access should be there for everyone. So that is our prime aim. But definitely, coming to your questions about the geographical distribution of this chronic kidney disease, you can see there are a few things which are very common. Like Dr. Khullar has pointed out, that diabetics is across India is equally common. whether it is north, south, and approximately, as you have also pointed out, your 30 to 40% of all diabetic patients develop chronic kidney disease, and subsequently they land up with an end-stage kidney disease requiring dialysis and transplantation. So that is one. Hypertension per se can cause chronic kidney disease. There are many other autoimmune diseases are there, and many are treatable. Why I want to highlight these portions, like the glomerular disease, which ultimately leads to chronic glomerulonephritis and ultimately to end-stage renal disease and dialysis. So these patients, when picked up at the early stages, can be treated, and some of the disease can be reversed back. So population, as I will say, I see both kind of the patient coming from the urban and rural populations both. It is equally common. You understand, diabetes is very common among the rural population also now. So, but definitely it is a lifestyle disease. It is thought to be hypertension lifestyle disease, which is more common in urban populations than this rural populations. But it is not uncommon now in rural populations also. India is the diabetic capitals of the world. So here, a lot of diabetics are there. So patients comes equally from both. But what our data has revealed that lower socioeconomic group of the patients are more vulnerable for developing chronic kidney disease. Patients who are less educated, matriculations or less, they are more vulnerable for developing chronic kidney disease. One of the factors what you have pointed out the geographical variations, so I will try to point out the one condition called chronic kidney disease of unknown etiology. That is very common across the coastal belts of even India or across the world. You will see the Andhra, you can see the Odisha, you can see some of the coastal belts across India are very prone for developing chronic kidney disease of unknown etiology, even in Goa, these coastal belts. This is some environmental toxins which is causing this kind of the injuries. Some of them has been identified, and some are still even nephrologists, we are also puzzled why this is so common in that group of the patient. Other vulnerable population is our farmers who works in this heat. There is subclinical dehydration. All subclinical dehydrations leads to some subclinical kidney injury, and that cumulative and repeated injury ultimately leads to chronic kidney disease. And that farmers working in the heat, in the hot environment, sweating all around, not having the facility for drinking water. So these all cause subtle injury, and gradually that cumulative injury results into the chronic kidney disease. So that is concerned when you look at this geographical distribution of the chronic kidney disease. So rural and urban, I don't see too much of the differences. Rural populations, low education levels, low socioeconomic groups are really vulnerable populations. They do not have equal access as this urban population has to for any kind of the kidney care. So that is still there. You have pointed out about the dialysis facilities, about this. So we should thank everyone to this Pradhan Mantri National Dialysis Program. And I think initially when I have joined, our 70-80% patients were not getting any form of the dialysis because there was no facilities for giving the dialysis, no infrastructure for providing dialysis to this large population. At present now, in every district, there are at least approximately most of the districts of Uttar Pradesh has some dialysis machines, and the pupils need to go back and get the dialysis done at their district hospitals. So, but still, what is the challenge for this program is basically the quality of the dialysis which we offered at this district hospitals. So that remains the challenge. But at least we are able to provide some form of the dialytic therapy at the periphery. So that kind of things are that we are improving on this front, but definitely this is not sufficient enough to cover all populations. And just giving you the example, it is estimated that approximately when you look at the 25 crore of the population of the Uttar Pradesh, approximately 50,000 people would be requiring some kind of the renal replacement therapy, some kind of chronic kidney disease care. So you are muted, Kamal.
Sorry. How many of them? Can you repeat the figure?
It is estimated that the 200 per million population is usually the patient having chronic kidney disease or some kind of advanced chronic kidney disease, interstitial kidney disease. So when I look at the 250 million populations of this, then definitely it is coming about the 40 to 50,000 people would be suffering from this. So is our infrastructure is ready to take care, cater these populations? It is no. When you look at the infrastructures at across Uttar Pradesh, only transplantations done at the few centers like the SCPJMS in public sector. I'm just giving you in SCPJMS and Ram Manohar Lohia Hospital in Lucknow. Some of the private sectors are doing, but this is not sufficient to take care of this number of the populations. So still we are far behind what we require. And but optimistically speaking, at looking at when the attention of the government went towards this chronic kidney disease and its bigger problem, definitely we are moving forward, and we look forwards to have the better care in the future.
Absolutely. Thank you so much, Dr. Narayan. Quite important, facts which you have mentioned here. Let me go to Dr. Mahapatra at the Ram Manohar Lohia Hospital in Delhi. We talked about diabetes, one major factor contributing to kidney diseases. Hypertension is definitely another one. Some of the factors which are, a little talked about are the one which Dr. Narayan just mentioned about. Chronic kidney diseases of unknown etiology and something where the factors or the risk factors are not causes are not clearly established. Maybe the environmental, which he mentioned. Dr. Mahapatra, another major area which we see is contributing a lot to kidney diseases is obesity. And also, obviously, the many of the other factors which Dr. Narayan talked about, especially those related to the lower socioeconomic, strata of the population. You are at the premier government institution in Delhi. Obviously, a lot of patient load which you get belong to the lower socioeconomic section of urban population, and maybe outside of it as well. What are the trends, the risk factors, the causes which are coming up prominently in front of you for kidney diseases? And where do you see the major challenges also coming up in terms of treating them or providing equitable care, as enshrined in this year's the theme of Kidney Day?
Thank you very much. At the outset, I definitely want to thank on behalf of, and most of the things
Sir, your voice. I think Dr. Mahapatra got on mute.
No, I am not in mute.
Okay. So the voice did not come after one or two lines.
Okay? Is it okay now?
Yeah, it is.
No, you are audible, Himanshu. Please go ahead.
Huh?
You are audible. Go ahead.
Audible? Okay. So one thing, the major problem is the younger population. Means around 30 years, 40 years populations, we see the kidney diseases are more in comparison to the elderly population. Although elderly population have, but the nation, the way we are seeing, for example, now the financially we are coming to almost world third number. But if you see at this point of time, the kidney disease death is in eighth number, and it will also projected, means in the 20247, it will be on third position. So no doubt, equitable care and the preventable care is very much important for all the patients. About the cause, you said, most of the 30 to 40% patients, we don't know the cause. See, about the CKD of unknown origin, that is different from what we are seeing in our OPD patients. that is not the CKDU. Basically, CKDU means will distribute in the clustering population. For example, as Dr. Narayan Prasad said, in the farmers, in a village. As a means the government of India, I visited this Andhra Pradesh and Srikakulam and the Odisha also. We have seen in one village at one area, 70-80 population died. So we could not find out the cause. We have tested the soil, water, patient's blood, whatever. It needs a very extensive study, but so far we have not found out. But the way we are seeing in the government hospital, these are mostly referral patients. They are coming and they are very late stages. That is, we have the Indian Society of Nephrology also, we have studied. The problem is the late stage of presentation to the at least tertiary hospitals. It is again a problem because we have only the option of dialysis and kidney transplantation. As Dr. Narayan Prasad said, the transplantation option is very limited. So, and the dialysis option, though it is increasing, but the way the kidney disease proportion is get increased, we cannot provide the dialysis for everyone. So only the option we left out is our prevention aspect. So prevention, we have to do that at any cost. That has to be because as the nation is doing the hypertension and diabetes door-to-day survey, we would like to, means our Niti Aayog madam is also here. We would better to include this urine examination, serum creatinine, in addition to this diabetes and hypertension and door-to-door survey at the village level, at the community level. In that way, we can pick up the kidney disease at the early stage and you can preventable. No doubt, the doctors, nephrologists, they are also less, but the primary care physicians also can the preventable aspect. So in our hospitals, the ways, all periphery hospitals, or even it's a private or public, whatever means government, whatever, the load is definitely huge in everywhere. Because poor populations are affecting more, that's why we are facing at the patients, they are coming with nothing, we don't have money. At least our job is to counsel the money first, how to arrange the money first, then the treatment second. In that way, we are managing.
For that,
and in addition to the diabetes,
Ayushman Bharat.
Yes, yeah, Ayushman, but the people's education level is so poor. We have some counselors, but those counselors also not insufficient to counsel this number of loaded patients. So that is the one challenging aspect of the treatment aspect. I'm saying about the etiology, diabetes, hypertension, and some immunological diseases. Dr. Narayan Prasad also pointed out. Other than that, stone diseases, urinary tract infection, congenital diseases. For example, if children with some congenital anomalies, and the World Kidney Day theme is the drug. Now the medication, and WHO also at this point of time, patient safety means treating the medication, appropriate medications and appropriate time. That is also very important to save the kidney. Because if it is not there, then at the end, they will come to the nephrologist and by ending kidney is almost lost. And the surgical procedures also. Obesity, you have taken a very good point. Not only the obesity, it is almost diabetes, hypertension, obesity, all are the metabolic syndrome. See, our blood vessel, kidney is a blood vessel, and our whole heart is a blood vessels, all are connecting to each other. So if one organ is getting damaged, the other organ will definitely get affected. So in that way, the metabolic syndrome, childhood obesity, so many the dietary aspect also, the pizza, burger, and all. Unless you control those things at the root level, that is very difficult to control. So we need a mass campaign for this preventive aspect at the school level, at the primary care level, at the CSC level, at the institutional level as well. So I think without that, there is very difficult to manage the chronic kidney disease, the pandemic. You can say it is a pandemic now, the way it is growing. Say 1 in 10 means it's very huge. 10 population, if you see, one will be a chronic kidney disease.
Thank you so much, Dr. Mahapatra. Thank you.
Thank you.
I think you have set the stage right for now, Dr. Urvashi Prasad to comment on it. And that was my purpose also, so that we can hear from the experts and the people who are bringing these interventions to the masses, and then hear from those who are involved in the policy making side, that how they are looking at it and how they are, provisioning health for the people. So Urvashi ji, one of the major, I think consensus, if I can say, is coming up that prevention is one important area. And I remember our discussion in the last kidney summit as well, and I heard a lot of encouraging thoughts from your side also about how we have to strengthen the prevention piece around many diseases, and especially the kidney disease as well, as we are talking about kidney health today. So when it comes to prevention, and as Dr. Mahapatra also highlighted, that a nephrologist alone may not be the target set to in terms of strengthening the prevention system around us. You have been very vocal and also very hopeful around the health and wellness centers network which is being built, obviously, which has a lot of focus on the prevention side as well. So how do you see that contributing towards managing this growing challenge, where the NCD or lifestyle diseases primarily triggered by a lot of lifestyle choices, unrestricted or unregulated intake of sugar and salt, and many others, leading to diabetes, leading to hypertension, leading to obesity, and then leading to things which are more critical like kidney diseases. So one, this aspect, and the other aspect of how we are, kind of educating, training our health workforce at the grassroots level to start picking up these early signs for these diseases, which can help reducing the overall burden on the government as well of setting up higher tertiary centers and, looking for better kidney care mechanism, and also reducing the suffering of the people, because ultimately, it is going to inflict suffering if they get into kidney failure or dialysis or, so on and so forth. Urvashi ji.
Yeah, thank you, Kamalji, for having me here once again. And the clinicians and you have raised a lot of issues. So let me try to address them, and as many of them as possible. So I think, it's very clear that with any chronic disease, and it's true for, obviously chronic kidney disease as well, but really any NCD, that given the sheer numbers in our country, we will never have, enough hospitals or enough resources if everybody keeps presenting at late stages. So I think that is something that is very, very clear, and that is a realization that, we've been also trying to bring into everybody in the system, including the policymakers at the highest levels, that we cannot afford to keep waiting for everybody to present, at late stages, because then invariably treatments are obviously more complex, the prognosis is often poorer, and the cost aspect is tremendous. So I think clearly that's what we are using as a very clear message to shift the focus onto the preventive side and the early detection, screening and early detection side. Now, specifically with respect to chronic kidney disease, what with some of the things we're trying to do. Of course, we are focusing on the major risk factors, like we spoke about already, that, diabetes, hypertension, but there's also, malnutrition, which is obviously linked to poverty. There are also a lot of environmental pollution related issues, a lot of environmental contaminants or nephrotoxins. Of course, we might not have the full body of research available on all of them yet, and a lot of the research is still ongoing. But a lot of the evidence is also available to a great extent, that there are particularly certain parts of the country where these toxins, whether it's in the air, whether it's in the water, they certainly don't help this whole issue and possibly worsen people's likelihood of developing these conditions. So I think and for all of that, there's clearly a need for a public health approach, because those are all preventive aspects. Whether you're trying to provide good environment, water, sanitation, nutrition, those are all intersectoral issues. They need collaboration across multiple ministries and departments in the government. So that is one part of it that we're really trying to push on, because that will be beneficial not just for chronic kidney disease, but for a lot of other health issues that people end up developing as a result of these common in a way risk factors. The other part is on screening and early detection, and obviously screening, we don't have a large scale screening program specifically for this, but we're certainly trying to see how we can at least do screening for the higher risk populations, people who say have a family history of chronic kidney disease, people who have autoimmune diseases, and of course people with diabetes, hypertension. So that is one thing that we're trying to bring in, because if we can do some level of screening for such people, we're likely to pick up many more earlier stage kidney disease cases. And of course, that involves a lot of education of people within the health system also, because unfortunately, nephrologists, specialists, like specialists in many other areas, are still very limited. The distribution is still very skewed towards urban areas predominantly, that too not uniform across the country. And of course, as you know, that's a whole entire stream of work that we're trying to do on increasing the quantity and quality of specialists. But that is also going to take some time, and that's going to happen over time. So for now, the existing workforce that we have, the community health physicians, the people, like you said, our health and wellness workforce, centers workforce, workforce at every level, to at least be able to pick up some early signs and symptoms, or at least be able to take a call that, okay, this is somebody we need to potentially refer to a nephrologist. So that is education that we're trying to also do within the health system of professionals who are not necessarily specialists. So that is the other part. And of course, education also of people, because, clearly, there's a lot of education gap there. There's a lot of behavior change issues. You mentioned a lot of lifestyle issues. Again, these are things which impact across chronic diseases, and would therefore give us returns much greater, by investing in these issues. So we're trying to do all of that. And I think then, just quickly to touch on the other end, that, given that we do have a large number of people presenting at advanced stages currently, what are we doing for them? I think everybody mentioned the dialysis program. So that is obviously something that at the district level, we are really trying to strengthen, especially in public partnership mode, because, it's very clear that it's very hard for the government, to provide everywhere at that level of quality. It's still very difficult, because our health system is very, very diverse, and there's a lot of differences and inequities between states, even within states, between districts, there are huge differences. So if we want to provide that kind of quality at scale, we know that, we'll have to have a kind of public-private partnership mode. So we're trying to certainly bring that in at the district hospital level, so that as many people, and pretty much everybody, so that can eventually have access to the dialysis services. We're also working on the transplantation program. And again, this is not just specific to kidney. This will benefit obviously various other types of transplants also, but specifically on organ transplantation, on transport of organs, because there's a lot of organs that don't reach people in time, or they are available, but we're not able to match donors with the recipients. There's various issues. So at that end of the spectrum, we're also trying to strengthen that program, look at the transport issues, look at the regulatory barriers, look at the interministerial, interstate coordination issues. So in fact, that is something that Niti Aayog is really very heavily involved in presently. So those are things where, and of course, insurance you mentioned. So those are at the other end of the spectrum, people who already have this condition. What do we do for them? And there's a lot of improvement we need to bring there. But I think clearly the message is that the focus has to be on the first part that I spoke about, because we are simply too large a population to just afford to wait and let people come in at those late stages. So that would be my kind of main message.
So a stitch on time saves nine is something which we are, trying to build around, and prevention is obviously, one of the major focus area and has to be that way. My next, set of questions which I would like to, take input from all the speakers is about how the technology is helping in terms of providing a better care to the patients, and what are the the new innovations and advancements helping again to take the care to the larger population in a effectively, and it should be accessible as well. So let me start with Urvashi ji, with you only, because at Niti Aayog, you in general, you guys try to look into a lot of new innovations which can be useful for the public health interventions, and can also be kind of easy and helpful in terms of understanding the challenges and also tracking the progress. So when it comes to your whole prevention piece, and where you try to put together a strong health and wellness system where prevention is the focus area, and we being a country where data has been sparse, conventionally, how do you see the role of tech, data, the new innovations, the the telemedicine, all these things playing a role in terms of achieving a better outcome in term, when you look at prevention, and also early screening, early diagnosis of these diseases, which can be then, kind of go to the next level of tertiary or secondary care.
Yes, so Kamalji, I think again, technology, there's a lot of potential, but I mean, it's a very important enabler. But we still need to figure out how to fully and properly integrate it, with our health system, especially at the primary care levels, the in the rural areas, the remote areas. I think with COVID, we made a huge kind of leap. There's no doubt, especially with things like telemedicine. And there's obviously a lot of applications that we are looking at, post or leveraging, telemedicine, especially for monitoring, chronic conditions. And this is also one condition which comes because a lot of people are living with this for many years at a time now. And so definitely the remote monitoring through technology will be a necessity in many ways. But we have to, of course, make sure that it is reaching out to the the people who need it the most. I think that is still the divide with technology is still, from a government's point of view, one of our biggest challenges, because we obviously we know that with telemedicine, even people in fairly remote areas were accessing telemedicine, and they still are. So there is definitely that advancement, but like I said, we're a huge country, so we really cannot ever and certainly not at this point say that everybody is getting access to it. So I think that is one area that we are really working on, using technology for remote monitoring of a chronic condition like this. But we're also looking at integrating technology at the health and wellness centers, to make the screening, the diagnosis that I was talking about, of many conditions, but in this particular case, screening, more effective. Also identifying, though you talked about data, so we're also trying to see, of course, digitizing the health data as much as possible, and building up these health records, because then we'll be able to do more targeted screening as well. If we can quickly identify, okay, these are our at-risk people, these are the diabetics, these are the hypertensives, these are people, with other risk factors, then our screening can become more targeted, more effective, and more efficient. So I think that is another application we are looking at. Of course, technology tools to reach out, to larger numbers of people in the patient education, it's starting to play a big role now. And also in health provider education, like I said, that we have a lot of the modules, digitally created on training, which we are now able to, disseminate much faster, more effectively across the country, across our health centers. And again, I'm talking at the primary level, at levels where you don't necessarily expect, technology to already be there. So we're able to now use it. I think we have been able to democratize, access to it to a great extent, but there are still gaps and there are still challenges, and I think that's what we are focusing on. So in a nutshell, I would just say that applications are tremendous at every level, whether it's in education, whether it's in training, whether it's in helping us, identify populations for screening or high risk populations, or just systematize the data, which we can then use artificial intelligence to, really give us faster, quicker diagnosis, better, more targeted treatment options. So there's huge potential applications, and of course the telemonitoring and the remote monitoring. But clearly we need to focus on identifying and which populations it's harder to reach technology to, and how do we make sure that they get the benefits of technology. So I think that is the part that from a government point of view we're really focused on.
Thank you so much, Urvashi. Yeah, I'm sure the way the digitization and the digital health mission has been kind of promoted and being supported. I'm sure it is going to help a lot, and definitely it has a lot of application and interventions which can lead to better access of care, or even if the information that way. You talked about training and skilling as well for the health workforce, which can be fairly effectively ensured through this. Let me go to Dr. Bansal. Dr. Bansal, so technology is one side where we can reach out to a larger population with the information. We can also maybe it utilized for identifying the early signs and maybe the screening also. How do you see the overall technology getting into the in terms of improvising the kidney care, in terms of the treatment, in terms of the surgeries required, in terms of the medication compliance? How do you see the technology playing a better role, and how much of it is being used at your level, whether it is for information and education dissemination, or for maybe training the physicians workforce, for CMEs, or for making your patients more compliant on the medications? How do you kind of involve technology at different level?
Yeah, thank you, Kamal. I think I'm more clearly audible now. So we trying to do the education, which is very important part of the awareness from the Indian Society of Nephrology. This thing. So we have created a social media of the Indian Society of Nephrology, which have the Facebook, Instagram, and YouTube, and we are promoting it through the various languages, the information to the all across the country. So this is a very important part, that the people get the right information through various channels, which either be Twitter or Facebook or social media or YouTube. Secondly, if we talk about the technology in providing the treatment, now the better dialysis machines are available, hemodiafiltration machines are available, CRRT machines are available, so we can even the quality of the dialysis can be improved. I would take this opportunity because nowadays the number of the nephrologists who are coming out are increasing, and we have at least 200 or 300 nephrologists per year who are coming out. So we can really involve them in this providing the services through the PPP model, and we can improve the quality of the dialysis by involving nephrologists as much as possible in the government services also. If we talk about technology in surgery, so now we even the laparoscopic surgery and the minimally invasive and the robotic surgery through the transplantation is also being done in some of the selected centers. So the people who want it, who do not want to a bigger incision or the bigger surgery, this thing. So the robotic surgery has now become reality in many of the center, and I'm sure with the increasing expertise, the increasing the exposure, and we train more people, this would be more and more available. But then obviously this is a not be available to the masses. Our more focus should be on the providing the diagnosing them early, prevention, and once the patient is diagnosed, to provide the quality dialysis, for which we are trying to associate more and more nephrologists with this PPP model through the companies which are providing the services. And we had a discussion with the dialysis provider associations of India and Indian Society of Nephrology, coming up with the guidelines to improve the quality. I would just say one of my personal observation that before COVID, we were just doing the physical consultation. And after COVID and during COVID, the role of the digital and telemedicine became very important. And now I see many of my patients who coming from the far off area, like Bihar, UP, and other areas, they need not to come every time. So maybe once or twice I do their online consultation, and then once in 6 months or a year, they come physically, so that their cost and overall the carbon footprint is also reduced. So that's a very, very important actually change which has happened with COVID, and that's a welcome change because it involves a lot of cost the patient coming every time from a smaller place to the big hospitals in Delhi or in the UP or anywhere else. So I think technology has really helped us in that.
Wonderful. Thank you so much, Dr. Bansal. And definitely this initiative of the Nephrology Society is very, I think, much needed in terms of, collaborating with the dialysis providers and how you can ensure the better quality and, efficacy. Let me go to Dr. Khullar. Dr. Khullar.
One more thing about screening I would like to say, because this Dr. Narayan Prasad is the previous secretary of Indian Society and I'm the current secretary. So we started a project with the help of a pharma, and we actually targeted the high-risk population in the clinics of the primary care physician with a screening of diabetes and hypertension. These people to screen them with the urine protein so that we can diagnose them early stages. And we came out with the initial result. There are 40% of these people, they have some kidney disease. So this is the importance of screening if you target the population. So that project is going on, and we hope to bring out more data for that. That is the purpose.
That's, I think, very much needed. Dr. Khullar, how you are utilizing the technology, which is helping both in strengthening the prevention of these diseases, as well as also effective treatment and therapy for the patients?
Well, I think before I answer that question, let me take it further from where Dr. Bansal left. And I think, Urvashi ji, this is for the policymakers, and you are doing such a wonderful job. And we know the enormity of task in front of you. I would want to start even earlier. I would want to start the screening at the level of the schools. I mean, the primary prevention would probably be the best thing to reinforce the lifestyle changes in children. They are our future, we know for sure. And if we target the screening at the level of the schools, because you see, gone are the days when we believe that, okay, the screening from chronic kidney disease should start only after the age of 40, not any longer. We realize that diabetes can happen much earlier. Diabetes can affect the kidneys much sooner. And more importantly, diabetes is not the only problem we have in hand. We have glomerular diseases, which are going to affect the children much earlier, much sooner. And all that it takes is the urine examination of these children. If we are thinking that hypertension is only a disease of the elderly, we're going to miss. We are having a rampant obesity in our children population. And if we were to measure their blood pressures and only do a urine dipstick, which will pick up protein, which will pick up any evidence of RBCs, I think we're going to be able to screen a lot of these patients who actually could progress onto much advanced forms of chronic kidney disease. And by the time they do present to the doctors, forget about nephrologists, even to the primary care physicians, it's generally too late. So we have to catch them young. And I think as Dr. Urvashi highlighted, this country is not in a position to waste all its very well-earned resources just to our ignorance. And I think we need to act fast. We need to do the screening. And that answers your question, how we are taking care of taking advantage of the digitalization. In fact, and even further, taking the help of the AI-generated algorithms, we have to target the right kind of population at the right time. And I think, of course, the social media awareness is only going to make our task rather easy. What Dr. Bansal was referring to, COVID has taught us many good things as well. We now know how to best reach out to the far-flung areas, to the remotest of the areas. And if we can give the right kind of messages to the people in the remotest of the areas, I think we are actually going to prevent. Now, let me give you another very interesting figure. You see, we are looking at crores of Indians getting chronic kidney disease, but only just about 200,000 on a yearly basis requiring what is called renal replacement therapy or reaching a stage of CKD stage 5. Where do the others go? I mean, it's not as if they've disappeared from Earth. It is because we lose majority of these patients to comorbid conditions, to heart disease. They die of their cardiovascular disease rather than reaching onto a stage of dialysis. So thankfully, they're not reaching the stage of requiring dialysis. But is it some kind of consolation? The answer is no. We are losing our precious population to non-communicable diseases now. And I think we need to take the help of the newer technologies. Well, new technologies will actually be relevant in a very small population. People who can actually afford anything. We have enough of Indian population who are rich enough to afford everything. But here we are looking at the larger perspective. We have to accept the fact that our main aim is towards the bigger chunk of population, and we need to do, and the only way to help them out is by preventing the disease. Start early. It's not just diabetes, it's making the lifestyle modifications. But the most important thing is screening. And to my mind, that should start at the level of the schooling so that it inculcates a kind of habit in the children to take their health seriously and before it is too late.
A very important, suggestion, Dr. Khullar, and I am sure that helping children build healthy habits will not only yield result of lesser prevalence of disease related to kidney, but overall we will be having a much healthier, happier population if we are able to build that along with the screenings. Yes, Dr. Khullar.
I'm sorry, I'll just interrupt. I actually have faith in this statement because when we taught children to say no to crackers, it really made a huge difference. You can see the effectiveness of that campaign, say no to crackers. And if we were to talk positively to our children and tell them, say yes to healthy lifestyle, I think it's going to make a huge difference.
Absolutely. Let me just get a very small intervention from Dr. Urvashi. Dr. Urvashi, you are there? Though I am running out of time and I will just go to Dr.
Yes, I'm here.
Question came to my mind, when we talk about intersectoral, collaborations, whole of government approach, whole of society approach. It has been a very regular suggestion and obviously the most important about how we take the health message more seriously to the children, which can yield wonderful result in terms of, in many parameters, in many of the aspects. for which we struggle at later stage. Urvashi ji, is there any really a concrete discussion and collaboration happens between Ministry of Health and Ministry of Education? Do they talk to each other and they really, build up some kind of mechanism that how both the ministry can work together and ease each other's, burden in the future?
Yeah, so this is, in fact, as the doctor was speaking about it, I was just thinking, so it's been probably the program closest to my heart, the school health initiative, and I've been working at it, now for over a decade. So across different governments, also even with the earlier governments, I was working on this issue, and I think it's been a very big challenge for us, no doubt. Even to get two ministries to collaborate is very hard in our context. But I think we have now started, to make some headway, and I think especially now at NITI, the school health program, and of course that includes a number of these initiatives, that the doctor was rightly pointing out also. And I think, I'm the biggest believer that we have to start young, and especially in India, because in India, most of the chronic diseases present at much younger ages. Even if you look at the cancers, which in the Western world might happen in people who are, 60, 70, 80, in India, they all present at often much, much earlier ages. Younger people getting, those conditions. So I think, definitely I am personally a big believer in this, but I think now even at a government policy level, we are starting to see a lot of traction on making school health a very important platform. And NITI, we are really trying to bring all the stakeholders together, because that's exactly what NITI's mandate is. That to help not just two ministries but multiple ministries be able to come on the same platform, to help different state governments come on the same platform and learn from each other. So we are trying to do all of that. And in the school health, in fact, even the mental health part is now becoming a very important issue, because even with mental health, we are saying we need to start early. We cannot afford to start late.
Thank you, Urvashi ji. It's so assuring to hear that a lot of effort is going on that, and also your passion towards and your, I think, dedicated efforts going on that side. I'm sure we will be happy as an institution, and all our experts would also be very, happy if they can contribute in any way in terms of strengthening your efforts and the government's effort in terms of taking this critical information to the school level, to the children of our country. Dr. Narayan Prasad, a small 1 minute, maybe your kind of concluding remark. What are the important takeaway you feel we should be, carrying from this session, and also for the government, for the clinicians, and also the people who are involved in the public health, strengthening.
Yeah. Thank you, Kamalji. Basically, when you talk about the technology, and just I'm trying to point out you, we have initiated our Department of Telemedicine at SGPJIMS in 1990s, and now it is full-fledged since 2000. And we cover many districts of Uttar Pradesh, many medical colleges across India, and then to Africa also. International communications about the teachings are going on. Recently, we have launched Tele-ICU. So Tele-ICU, the hub would be there at SGPJIMS, and 7 medical colleges ICU has been connected right now. So that is another important advancement in
Tele-ICU means tele-surgery unit.
Tele-ICU, intensive care unit.
ICU.
So
okay.
ICU, yeah. So that hub would be at SGPJIMS, and 7 different medical colleges of this Uttar Pradesh will be connected with this hub, and there will be monitoring from SGPJIMS. So that is our second part. Third important part, as you are talking about everyone, this is time of the artificial intelligence. And we see a number of pathologists right now I'm talking about the nephropathologists, which are relatively far less than required. And artificial intelligence can be quite utilized. I'm just giving information since Urvashi Prasad ji is also here today. So that can be quickly implemented. So that part can be taken care. Artificial intelligence in radiology is coming the big way. So there again, at many of your district level hospitals, PSC levels, you have no radiologist available. So there it can be utilized. It can be utilized in the emergency services. Coming to the preventive part, the most important, and everyone talks about the primary, secondary, and tertiary care of the prevention. One important word is primordial prevention. That is promotive. Rather than thinking at when the patient will develop the diabetes and then we are screening for the protein in the urine and looking at why the patients develop diabetes, why the patients are developing hypertension.
So Dr. Narayan, I think one of the suggestion, and which is taking the health information and education to the school level will help building the healthy habits, which will even be health promotive for health rather than just being preventive.
Yeah, that primordial prevention is coming by big way, and even artificial intelligence can be used in many persons. Suppose any person having the kidney disease, family history of the kidney diseases are there, and there primordial prevention by the genetic testings, you can prevent the children being born with the kidney diseases.
Yes.
So that kind of things needs to be implemented with the advanced technology. So I think we should have this, as everyone has pointed out, we cannot take care of these large populations straightway, but prevention is the answer for all, and we should work all together.
Absolutely. Thank you so much, Dr. Narayan. And I think you have ended it well that we need to work together for the promotion of prevention of health, prevention of diseases, and promotion of health. And then only we will be able to kind of realize the dream of building a healthier, happier society, a nation which can really progress well, which can get the fruits of progress, the development to each and every one of the society with a healthy kind of the life which they can avail. Thank you so much, all the experts and speakers who joined us on this inaugural session of the Kidney Care Summit this year. I'm sure during the day we will be having many experts and clinicians and public health enthusiasts sharing their thought. So let me hand over the stage, this virtual stage, to my colleague Dr. Behjat Moini for the next session. And thank you so much, and welcome all other speakers who have joined for the next session. Thank you so much.
Well, thank you very much, Kamalji, for this wonderful opportunity. It's been a great session. I thoroughly enjoyed it.
Thank you.
Thank you, Kamalji.
Thank you.
Thank you.
So good afternoon, everyone, and thanks to Kamal sir for handing over to me. So we'll be starting with the session 2 of our Kidney Care Summit, which will be talking about bridging regional inequity in kidney care in India. And let me take this opportunity to introduce our very esteemed guests for today for this session. I have with me Dr. Manisha Sahai, who's a professor and head Department of Nephrology, Osmania Medical College and Osmania General Hospital, Hyderabad. Welcome to the discussion, ma'am. It's a pleasure to have you with us. Next, I have Dr. Sampat Kumar K, Senior Consultant and HOD Nephrology, Meenakshi Mission Hospital and Research Center, Madurai. Thanks for being with us, sir.
Yeah.
I'm also joined by Dr. Sadanand Busari, who's a Senior Nephrologist at Shubham Karoti Kidney Care Hospital, Maharashtra. Welcome to the discussion, sir.
Yes, thank you, madam. Thank you.
I have also with me Dr. Arun Kumar K, Chief Urologist, RJ Hospital, Chennai. And for the moderation, I have with me Dr. Tarun Kumar Saha, who's a senior consultant nephrologist and transplant physician at Yashoda Hospital, Secunderabad. So over to you, sir, to lead the session. And welcome to all the experts, and thanks for being with us.
Thank you very much. I think, let me just go to the, just give me a few seconds. So our this session's topic is bridging the regional inequality in kidney care in India. We know that the kidney cares are not uniform, not only in India, throughout the world. And there are several reasons for that, which are social, economical, cultural, regional. There are various myths and which are associated with it. So we have so many, about 3 or 4 panelists. I'll first go to Dr. Manisha Sahai for her questions, which, just a second. Let me retrieve the questions. Manisha, you got your questions with you? I forwarded to you. Dr. Manisha?
Yeah, hello, good morning, Dr. Saha. Good morning, everyone.
Yeah. You start the ball rolling with your opinion about the regional differences in the kidney care in our country and how we can improve this.
Okay, so thank you, and thank you for the organizers to invite all of us here on the day before the World Kidney Day. So talking about the disparities in our country, so India is a huge diverse country. We have 29 states, we have so many union territories, and there are differences in these states. Socio-economic differences are there, religious differences, cultural differences are there. But despite that, country is one. We have national schemes which are running throughout the country. We are all aware of Ayushman Bharat, as well as we have regional schemes. For example, in Telangana, we have a free scheme called Arogyashri scheme. Similarly, all the states, most of the states have their own schemes to support their population. Now, I was asked to speak on how do we address these disparities, different disparities, which bother us at our level. So I am a professor of nephrology at one of the state government hospital in India. It is the leading hospital in the state of Telangana, and it's a completely state-funded hospital, which shows the true picture of our country. We have big institutes in the country. We have many private hospitals in the country. But again, the majority of population is served by the government medical colleges and government hospitals. Our hospital is under Usmania Medical College, which has a daily OP footfall of 7,000 people. Now, how do we address the social inequalities in the population we get daily in our OPD? So we have different sorts of people coming to us. Most of the times, the people coming to us are poor socioeconomic status or those from middle or high income groups who have exhausted their resources and have finally turned towards a government hospital. So despite it being a government hospital, it's adequately funded by the government of Telangana as well as under the Ayushman scheme, so much so that everything available right from OP services to IP services are free. So whether it's a low socioeconomic person or a high socioeconomic person, the disparity may be in socioeconomic status, but the treatment provided is free, meaning the standard of care is given. There is no difference between high income or low income. We follow the basic minimum standard of care, which is available. For instance, in a patient of kidney failure, hemodialysis is available free of cost for everyone. High-end therapies like CRRT, which costs around 20 to 30,000 bucks a day, is completely available free of cost to the person. Even transplants, both cadaver, live transplants with immunosuppression are available free of cost. So regarding the socioeconomic disparities that we don't see here, but we have some other disparities. For example, we have a lot of gender disparity. The daily footfall is around 70% males and 30% females, whether we are talking about the OP or the IP or dialysis unit or even transplant. And now we are creating awareness programs to deal with this disparity. We have special OPs for transgender population as well. I mean, it is one of the first government hospitals in the country that has a separate transgender unit. In fact, when we were students, we never bothered about transgenders. But now we understand that they have their unique problems, be it a nephro problem or any other problem. They have specific issues which need to be addressed in a transplant, and we have a transgender unit as well. So we have facilities for differently abled people, and we have pediatric and geriatric wards as well. So the disparities do exist. The socio-economic disparities exist. I'm not saying everything is rosy, but at least now our eyes have opened to these disparities, and we are looking and trying to rectify most of them. Regarding the socio-economic, yes, we cater to the low socio-economic strata. Many hospitals in Hyderabad, private hospitals, as well as institutes, they look after the higher socio-economic strata, and it's a seamless service between the two because of the existing programs by Ayushman Bharat as well as Arogya Shri scheme of Telangana, where all services are provided free of cost to the patient. So I hope that adequately answers your question, Dr. Saha.
Yes, we'll come back to you again. Then we will move to Dr. Sampath Kumar. He is a very well-known nephrologist from South India, and he's got a very vast experience. Dr. Sampath, could you tell us?
Yes, Dr. Saha, good morning.
Yeah, just few more sentences. Could you tell us particularly the problem what you encounter when you treat the ESRD patient, when you try to shift them from hospital care to the home-based treatment? You can give your opening remark as well as take up this question.
Yeah, see, when I started my practice 30 years ago, the concept of long-term management of chronic kidney disease was in its infancy. Many patients were left to die. The dialysis was offered only to a minuscule percentage of people. But now I see a sea change in the whole management of chronic kidney disease in our country, which is very, very heartwarming. We have very busy dialysis units, both in the public sector and also the private sector, which was unthinkable. We used to only read about the complications of long-term dialysis patients in the textbooks. I thought it will never be seen by people who are practicing in the developing countries, but we see all those. And so this is a real credit to the whole nation that we have moved forward as far as the treatment of chronic kidney disease is concerned. Even though we have miles to go, we have achieved something remarkable in these 30 years. The question about management of renal disease from going from the hospital-based to the home-based therapy is, I'm sure you're alluding to the management in the form of peritoneal dialysis, isn't it?
Yeah, both peritoneal dialysis as well as the home hemodialysis.
Okay.
You established a home hemodialysis program, which is not so easy in our country.
Yeah. So peritoneal dialysis is real. It is even today it is struggling to keep pace with the development of hemodialysis, but still it has a very important role to play in those patients who can have a good support, family support, because in contrast to the Western population where the patients themselves are able to do their dialysis at home, in India, we have this very peculiar situation of the caregiver always being tasked with the management of these patients, providing them with the regular exchanges. So this again,
do you think that this is because of our habit of most of the works are taken care by others, and we enjoy that, whether it was in Western countries, they have to do their household work and everything. And we
are always used to this type of living. So when a patient is down, so he has to be looked after by the others. This concept also filters into the CAPD. And to some extent, this has hampered the growth, because I feel that after some time, the caregiver burden is so much that they start reducing the dose of CAPD, and then it leads to multiple problems. So I'll
So
start with this.
how do you plan to overcome these difficulties? Another issue is that home hemodialysis setting. As you said, one is that the attitude. Any other thing that how you wish to overcome these problems?
No, I always tell them that they have to do their exchanges on their own and then take their health on their hands and do it. The second aspect is about the home hemodialysis. I don't think that we have made a great strides in the home hemodialysis programs in our country. And I feel that it may not also start up in the near future because of the enormous economics involved.
So I will come back again.
Yeah.
Before I would like to move to Dr. Sadanand. So what is your take on how do you sort of try to bridge the gap between the regional difference in care at your state, Maharashtra? I think you work in Maharashtra, so you can elaborate on that area, Dr. Sadanand.
Yeah, thank you, sir. Thank you for inviting me on this panel. I am really honored. To start off, it's very clear that one shoe does not fit all. So we have to, individualize the therapy as far as region-wise also is concerned. And it's like looking at whether the glass is half full or half empty. We can have a lot of problems that this is the problem, that is the problem, or look at the positives. So I would dwell on the positives to start with. The difference between the rural and urban is very drastic. I have been educated in Mumbai KEM hospital, and I stayed in Mumbai for 15 years, and 20 years back I shifted to a rural part of Maharashtra. So I have seen the metropolitan practice and the rural practice also. So what is the good thing that is happening in rural as of now is that the number of nephrologists that are coming out are increasing. So I would not hesitate to say there is saturation in the metropolitan cities, and the sun of soils are coming to the rural region, which is a big positive. The people, the students and the doctors, young doctors who were initially hesitant to come to rural, the trend is reversing now. And the people who are well-known families in the rural part, they are coming as experts in the region. So that is giving good positive to them also and to the society also. And there is definitely some emotional attachment in the people who are known in this region as doctors and families. So the care giving by the doctors is slightly personalized, I would say, as compared to that in metropolitan, which is more of professional. Though the technology aspect is lacking in the rural part, but with COVID, we have been pushed to the wall, and everyone has been made to use the technology in their own lives. Zoom meetings and the virtual discussions, which we are right now having, is a big positive from COVID. So that is the thing. Now, what are the difference or whatever is lacking in the rural areas is the skilled manpower. The nephrologists are coming to the rural area, but the skilled and trained dialysis technicians or the skilled nursing people are not there. And the nephrology orders are in place, but the actual care, last rope caregiving is a little bit shallow as compared to the metropolitan cities. Also, that is because of the staff-patient ratio, doctor-patient ratio in metropolitan cities is much higher as compared to rural part. And definitely the accessibility, the villages, there are many villages, the people have to, even dialysis patients have to walk 3-4 kilometers to come to the main road and highways to take their dialysis center vehicle. Supervision is poor, and definitely the awareness is low in rural areas. So the therapy, I would say therapy in terms of non-medical therapy here, like awareness, insurance penetration, and everything has to be focused more or equally as compared to the medical part. So only seminars and medical teaching that which says that you should do preventive education, get yourself checked, and you should go and detect yourself in early stages of CKD. That is definitely a big role, but non-medical part also needs to be equally addressed in rural part, which can be lower in the metropolitan cities. That's what I feel.
Good. So the one point what you mentioned, which I like very much, that is the number of technicians, because nephrologists are coming to the rural area, but not probably stay time. They're acting as a visiting to give the proper ESRD care in the form of dialysis. We need to have a more trained technicians. That aspect we need to improve, because if you want to really bridge the gap from the rural versus urban, the number of properly trained technicians are a very much essential in nephrology treatment. So just one more point, what I would like to ask you, that what about the stigma associated with the ESRD care like dialysis and all, particularly for the marginalized society people? What is your opinion on that before I move to the next?
That is a big nut that I have been. It's very difficult to crack here. It's a vicious circle that is happening in rural part of the world is that people are scared of dialysis. There are a lot of apprehensions about. I mean, I would go on to say, I may be wrong, but I would not hesitate to say that the situation is same for the transplant also. Though we hammer that transplants are always better than doing lifelong dialysis, but the stigma to dialysis and transplant is equal here. And I would like to narrate the reasons here is that firstly, because of lack of education and awareness, the people are diagnosed late in their CKD stages. And for them to accept that they will go on dialysis lifelong takes a lot of time. So, for example, if I have a patient who's been detected at stage 2, I have a lot of time on stage 3, stage 4 to counsel and hammer that ultimately we are going to go on dialysis. But somebody who comes to me at stage 5, the window that I get for him to counsel and he going into uremic convulsions and complications or pulmonary edema is very narrow. So people are getting into dialysis late because we do not have enough window for counseling. That's one. So whenever we start late, means patient if it come uremic encephalopathy or pulmonary edema in ICU, they succumb early. So the perception in the society that goes is that he was only on dialysis for 6 months and he expired. It is very difficult for us to explain them that the person has started late, and with complications. So the life expectancy is as it is lower as compared to had he started at stage 4 for fistula and something like that. Secondly, going on to transplant is similar thing happens here. Is transplant itself is costly. Though now in Yojana, the transplants are happening, but the medications are very difficult for the people to get. Their income in rural areas in few hundreds per day as compared to few thousands in metropolitan per day, I'm saying. So in transplant, what happens is after 1 year, 6 months, 1.5, 2 years, they feel that I'm feeling okay. I need not burden my family with the medications. They stop medications. They stop their medications, the graft fails. The graft fails, the patient comes back on dialysis or succumbs. So what happens is even that transplant is getting bad name because of we are at fault of counseling. Maybe we have to work on that. But this is a vicious cycle. The transplant fails in my next house, so I am scared of transplant now. Patient on dialysis succumbs early, I am scared of those. The perception that's going in the society is not correct right now. We definitely need to tackle this.
Okay, thank you. So we'll move on to Dr. Arun Kumar, and we are fortunate that we have a urologist with us. Generally, it is always the nephrologist who are given the preference, and we are lucky to have a urologist that we are with us. And Dr. Arun, the first question is that how do you coordinate with the nephrologist for the practice of the patients with kidney diseases? And let me tell you one very interesting thought. After I passed my DM from Chandigarh in way back in '94, and then joined the government setup, then changed to private. When you joined to private setup, there was a big issue of getting a transplant surgeon work in accordance to your opinion and ways. And I thought of joining general surgery and doing a transplant surgery course from Fiji to become a transplant surgeon come nephrologist. But I didn't have that much of courage to work out for 5 years to have that unique degree kind of thing. So it's the coordination is very important. So what is your take on that for the better patient care management to sort of decrease the regional disparity in kidney care, particularly in urological point of view?
Thank you for the opportunity, and a very good afternoon to all the esteemed panelists here. So the point is, the urologist gets involved into the transplantation, into the CKD part of the treatment fairly late, only in the transplant phases, especially in a non-urological reason for the CKD. Many times there is a particular element of CKD in most of the kidney conditions that we also see urologically. So maybe it may be stones, some renal obstruction, and that's why the interdisciplinary coordination needs to happen at a much earlier stage. Sir was actually telling the CKD 3 stage, CKD 2 stage, they get more time. So our part from the urology side to reduce patient-related difficulties is to start the coordination with our own nephrology colleagues little earlier, when the creatinine is not too high and the stage of CKD is a much lower, and thereby give a better plan for his future for the individual patient. And as to the transplantation, that process happening, we have very good regional centers, we have state centers which are doing a lot of free work also in transplantation, organ transplantation, government organizations. And there again we have a plethora of transplant teams these days who are a little bit free, willing to go and operate outside their comfort zone also. So nowadays we don't have transplant restricted to only a few centers, especially in my state, Tamil Nadu. We have a good team, good network of transplant surgeons who are willing to do the transplant procedures in tier 2, tier 3 centers also. And they collaborate with the nephrologists in those areas. And you don't have to bring the patient to the big city or the big center alone. Many times the care can be provided in a good unit if possible with the nephrology coordination.
So that another question to you is that what about the management of stone disease and urinary tract reconstruction surgeries? How do you see the challenges, and how do you help the community to take up these on their own rather than coming to the big cities and metros?
Yes. So again, there is a lot of growth in these technology advancements are there. You are able to get a lot of equipment, even transported along with the surgeons too. And we always have a habit of doing these camps, awareness programs. So when we go out to the periphery and try to reach out to those set of people, there we are able to detect the diseases a little bit in a better fashion. We have our own set of equipment too. Sometimes we do surgical camps. The Urology Association of India, the USI, does remote camps. That is, they go to a small town in, say, North India or South India, engage a hospital there and do free surgeries for 2 or 3 days. They bring in all the equipment, the C-arm, the lasers and other things. So there is a lot of community service being happening from the urology standpoint also. So we can do it in the smaller places without the patient having to move to any big city alone for the treatment. So that paradigm has changed. A lot of medical colleges in the peripheries, a lot of urologists are available, as sir was also telling, in the tier 2, tier 3 cities, and they are able to establish their practice and help the local population in a culturally more appropriate way too.
So, thank you, Dr. Arun. So, regarding the preventive aspects of kidney disease, we have a prior concept of a primary prevention and a secondary prevention. Primary prevention is that when you detect, prevent the kidney disease to happen at all, which is very difficult, for which we need to work at a different level. Secondary prevention is, of course, when there is a CKD, how do you prevent the progression of the CKD to the end stage renal disease? Now, I was just listening to the previous discussion for the before it was end, and there was a discussion. Dr. Kular was mentioning that we should have the preventive health checkup in the form of in the school to detect the kidney disease early, because as we know, the kidney disease not necessarily affects the elderly people. Sometimes the young people also suffer, and if we can detect them early, we will do a great job. So that was a discussion. But I would say that apart from the schools, we should do these kind of a health screening every year to all offices. And if we can detect their blood pressure, and those who have a high blood pressure, we must check their serum creatinine and urine examination to proceed further. That will be a very big way to detect the kidney disease at the early stage. Again, it's probably a secondary prevention, and primary prevention is to how do you prevent the diabetes or hypertension itself, but detecting them at early stage when they are office goers and they suffer a lot of stress, and if we can find that they are having abnormalities and BP and pulse, BP and sugar. So another thing, as Dr. Sampath was saying, that we are little averse to do our self-caring. So when we get a CKD patients and we tell them to do the home monitoring of blood pressure or sugar, they say that sometimes they say that, okay, I have a very doctor nearby to my house. I go to him and check his blood pressure. Someone wants to avoid the having a automatic BP machine and check it, document it, and bring it to the doctor's clinic to see how the BP variation is happening with diurnal rhythm or with posture, etc. So the attitude of not having self-care needs to be removed with proper health education as much as possible, because we know that the blood pressure sometime may be normal, some other time it may be abnormal in a particular day, and we need to know the diurnal variation and target it with appropriate drugs. The another thing is that after the COVID, we know that the telemedicine or the digital medicine has come. But what about the legality? Are we legally safe to give all kind of advices what we are giving over video call or not? That area also needs to be looked into, because the law has not yet spelled properly that whether we are allowed to assess the patient digitally over a video consultation or an audio consultation by seeing the report and give our opinion. Is it legally allowed or not? The clarity is not there. We need to have that, and we request the society to take up this, government to take up this and come up with a formula. So we'll go back to again to Dr. Manisha, where we say, I think we have no other panelist. Is there any other panelist I'm missing? So because Dr. Dhananjay is not attending. So Dr. Manisha, what do you think about the legality of video call or audio call where we give the opinion to our patient?
Okay, so before I answer that question, one comment about the previous speaker, like the transplant medicines I was given to understand are given only for 1 year in some of the states. So in our state now, government has made transplant medicines completely free of cost throughout the patient's lifetime. So one thing is that the government is providing free dialysis to all the patients. So dialysis packages are around 12 to 14,000 per month. Whereas the transplant package, the transplant immunosuppression package is 9,000 per month, 9 to 10,000 per month. So a dialogue with the government would be that if you're able to provide immunosuppression for transplant lifelong, it would be more cost effective than dialysis. So this is how it started in our state. And now people are more interested in transplant because they know that they will be cared for by life and it's a less burden to the government. So this is the point I just wanted to make. Now, coming to the legality, during the COVID period, these consultations, we had a government order also that these consultations were made valid, but that was for the period of COVID. And as Dr. Saha rightly said, as of now, we don't have any geo coming after that. So the first assessment of the patient should be ideally done in the doctor's clinic, and the follow-up assessments can be done over the digital platforms in case the patient stays in remote areas. Now, coming to this digital technology of teleconsultation, see, government has adopted it in Telangana. So now in our hospital, we have a portal called eSanjeevani portal, which is a government portal. And we are doing digital teleconsultations for OP patients as well as for dialysis patients. So every day we have a digital consultation room in Usmania, in the state government-run hospital, which was earlier run by Tata Services, and it is approved by the government, and Telangana government has given it the name of eSanjeevani. So what happens is that we are able to talk to the patient. We can see the patient. There is a doctor stationed there in that rural area, MBBS doctor, and there is a nurse. So there is an online form which is filled. BP is checked, weight is checked, all the history, and then we give our expert opinion. So this sort of consultation is much more comfortable for me because I know that the patient has been seen by the MBBS doctor. I can see the patient also. I can ask for physical findings, and it is a huge hit. The medicines also, we have drop-down boxes and we have to follow the guidelines. For example, UTI, you cannot prescribe whatever you want, start with phosphomycin or ferropenam or nothing like that. You have to justify. So there is some sort of audit going on. If nitrofurantoin was justified, why was the other medicine used? And we have to follow the guidelines. For instance, male UTI, what investigations I have to choose from the drop-down box, female UTI. So it's quite audited. It's still in the nascent stages, but it's a very good system. And we are able to connect with all patients sitting in the remotest part of Telangana. And I'm assured that at least the physical examination has been done by the MBBS doctor there or a nurse there. So that is good. That is one which is approved by the government. The other thing, other sort of a digital teleconsultation which is running. Now we have this hub and spoke model in Telangana. So in Usmania, for example, we have the hub center and we have around 30 centers under the Usmania hub. Each of these centers is located in district hospitals, and there we have each smallest center has 5 dialysis machines. And Dr. Saha rightly pointed out the problem of technicians. So we have now adequate technicians who are trained. We have a paramedical course. So they receive 2 years training. And now many of them are heading these centers. I'm not saying the problem has gone away completely, but it is much better than what it was before. When we used to talk about RO plant, the technician didn't even know what we were talking about. So now they are trained. The RO reports also have to be uploaded. So we are able to at least have a better grasp on these centers. And each of these centers, we are connected through teleconsultation. So I can talk to, so what we are doing is we have 30 centers. Now, so many patients are there. We have around 300 dialysis patients registered in Usmania and roughly around 3,000 dialysis per month. Similar 5,000 dialysis per month are going on in our peripheral centers under Usmania. So initially we were very scared because we are heading those centers legally. What about something goes wrong at that center? So now we have trained the people who are heading the centers, maybe an anesthetist, sometimes a gynecologist, MBBS. So they are the lead persons running the center. The technicians are under our control. And every month we are able to look at their report and daily we can talk to the patient. So they get the laptop to the patient's bedside. The patient is on dialysis, connected on dialysis. We can ask the patient, what was your native disease? Are you registered for transplant? Are you married? Show the fistula, everything. It's like a physical consultation. And it's again approved by the government of Telangana. So this is also under eSanjeevani dialysis portal. So regarding your question, whether it's legal in a private sector or not, as of now, we don't have a geo. But in the government sector, under the government schemes, eSanjeevani portal is being provided. So this is helping out. And another thing is we are utilizing this hub and spoke model of teleconsultation and dialysis for running screening services also. So same thing I would like to suggest to Government of India. See, we should be a very proud nation. We have dialysis network all over India and we have that Prime Minister National Dialysis Portal. I was so surprised when I had a look at the portal. Time to time, everything is recorded. So all the centers and 700 plus districts of India have these dialysis centers. What we can do is open a screening center at the same place alongside the dialysis center where the same staff the screening for the attendance of the patients. So that would be one way that we do not reduplicate everything, but we can do screening in the remotest district of India. Apart from what Dr. Saha suggested and the previous speaker suggested, the screening of the patients coming with the dialysis patients, which can be done at these dialysis centers. So we can have hub and spoke model of screening, hub and spoke model of dialysis, hub and spoke model of transplant as well. In addition to a school-centric screening and office-centric screening. And maybe each of us, whether we are in government hospital or private hospital, adopt certain area of our own city where we do door-to-door survey. So if we talk about big dreams, big projects that will cover entire Telangana, nobody can do it. It's a teamwork. So probably Usmania doctors cover the area around Usmania. Government can make that program divide. Your hospital, you can have an area around your hospital where you could do a door-to-door screening. So I think we need multi-point strategy because as we understand, see, dialysis centers, government has given machines, government has given, but it seems to be no end. We are running 5 shifts in Usmania. Is that correct? And still so many patients are waiting. We have so many CAPD patients, still we are not able to satisfy the need. So I believe in that prevention is the strategy which now we should focus on to reduce the burden of CKD. Because it is said a good doctor does dialysis, the better doctor does a transplant, but the best doctor is the person who prevents the patient from needing either dialysis or transplant. So
Absolutely
I think
perfect.
that answers your question.
Yeah, thank you. I think one particular terminology you also use is that adopting. I know a few years back, there was the concept started that all MPs has to adopt one village to develop. So we can have all the members of Indian Society of Nephrology should adopt a village to develop the nephrology services in that area. So
absolutely.
That one very good important takeaway can be from this discussion. Adopt something, contribute something to the society whereby we can decrease the regional disparity of nephrology service, which is the theme of the World Kidney Day. Now, Dr. Sampath, one difficult question maybe for you, that what role do you see private hospitals like yours playing in advocating for policy changes and investments in kidney care infrastructure at the state and national levels?
See, the policy change, because we
Can
don't
you do policy change?
Yeah, so it is very difficult for a private hospital to control the policy changes in the government. And most often, the private hospitals are at the receiving end. They feel that neither the funds are coming in and everything has to be charged from the patient's perspective only. So from the private practice, from the private hospital, it is difficult to change the policy levels of the government. It is impossible. But only way that we can do at our own center, at our own department, is that what we are doing is that we have selected regular screening programs at the villages around Madurai. And I was, to my dismay, I was able to find that more than 30 to 40% of the villages that I have surveyed, there have been an undercurrent of chronic kidney disease, especially CKDU. So this is a big elephant in the room which has not been addressed. So people are over focusing on the hypertension and diabetes, but CKDU is a big problem as we go down to the stage tier 3, tier 4, and also the villages, that these patients are all working tirelessly in the sun, and they have recurrent episodes of dehydration, and which leads on to slow progressive fibrosis. And CKDU has not been given its due in the planning, and I would like to highlight that aspect.
Great.
Yeah.
Great. We will come back to Dr. Sadanand. That in your experience, how do socioeconomic factors such as income inequality and access to insurance coverage impact the quality and outcome of kidney care for patients in Maharashtra?
Yeah, that is a major determining factor around 5 to 7 years back, I would say. But with a lot of government schemes and Yojana, NRHM, and different Yojanas in different regions, I think so that part, I have seen a era where we would say that you choose death to dialysis because we do not want a family to run out of their money and become bankrupt and transfer the loans to the next generation. I have seen that era where there were no Yojana, and thankfully, with the progress, now everyone in the country, as Madam Saha Madam has said, that everyone in the country has the opportunity to get dialysis free of cost. So that should not deter anyone, whatever the income group they come from, to take the facility, dialysis or transplant. So economic thing is now, as far as the basic dialysis is concerned, is off our back. That monkey is off our back. Whatever we need to do is we feel that I am always like you said, the technicians. We technically definitely need to follow guidelines and to do treatment. But what is lacking or what should be improved is the focus on quality of life. Neither the patient, nor the relatives, nor the technicians are focused on the quality of life. We tell them you have to do dialysis twice a week or thrice a week. They religiously do it. They go to the centers, they do dialysis, and they come back. But eventually they are getting weaker, they are malnourished, they contract tuberculosis, and eventually die of malnutrition and these infection related complications. So we really need to empathize our relatives also, the technicians also, and we need to increase our empathy about the patient and society. These kind of things will definitely help us improving the quality of our treatment. And once this is done, patients see, my relatives or my neighbor says that I have been doing dialysis since 15 years. He himself will opt for a dialysis early on. That is what impact we would want to see. The one more thing, I want to focus on the failure. Maybe it is failure in our region, but I see it overall I had an opportunity to interact with Mr. Dr. Mani sir, and he had an excellent protocol, SOP, and a framework to do primary intervention in the villages and primary screening. That model is not seen anywhere in the country. Have we forgotten that model? We have that model established by Mani sir. Why can't we implement it again at different places? It is,
well, I would
sir
say
has
that
successfully done that. We should adopt that.
Public health system has improved, and people are coming to the centers. When Dr. Mani did the study, that was about 3 decades back, 4 decades back. That time, the public health system was not at all established. Now, patients, even for the rural people, they have access to the public health centers, But as you say, that going to their house, reaching to their home definitely makes a difference. Okay. So the next question is to back to Dr. Arun Kumar. In your opinion, what are the most promising avenues for research and development in urology and nephrology that could lead to significant advancements in kidney care in Tamil Nadu and beyond?
Yes. So we are all now looking at the reasons, because many of us, when they go to the hospital, they want to know why the kidney problem occurred. And as Sampath sir was telling, the UCKD, the unknown reasons are more and more these days. So we have to basically do more and more research, especially in the high volume centers. And also the role of genomics does come into play in many situations. And we can specifically avoid certain interventions, medications in certain set of individuals. And like we are getting the DNA of every person. Now we are having the Aadhaar card, the biometrics for every person. Then next we have to have the almost DNA of all patients who are having this CKD. and get the genomic study done, and then plan the treatment or even predict how he is going to progress and what will be the response to the treatment. So that is a most essential thing. And whatever newer therapies that we do get, they all have to go through this process and finally get validated too.
What about the stone disease area, which is one of the very big thing which we probably discuss less often, which is one of the very much preventable cause of CKD, end-stage kidney disease, or other morbidities?
Yeah, stone is an enigma, as we all know, and still we are not able to fathom the exact reasons for it. Although prevention is a very important tool, and the lifestyle has to be tailored, that is more important. But more essentially, I believe in the stone disease is the proper awareness, information, and there are a lot of other alternative avenues to manage these stones. So that is the reason why the delay occurs many of these times, and everybody doesn't go to the urologist to treat the stone. There are so many people treating the stone, and in the correct way, in not the correct way, and that sometimes leaves the gap. Patient comes to you with already damaged kidneys, and then no matter what you do to remove the stone, the kidney cannot be returned to its original form. So this is also an important thing, the lack of adequate knowledge. This is not only among the non-medical people too, even among the well-trained, well-educated, literate medical people too, these sort of delays and mishaps keep happening. So that awareness has to be raised at all points of time.
So now, before we wind up, we will ask all panelists to have their one take-home message in 30 seconds or 40 seconds, not beyond that. We are approaching the time. Manisha, your chance. Take-home message, 40 seconds.
So we keep on discussing all these things. The key is implementation, and that we have to do. You talk about school healthy food screening. First, change the kitchen of the schools where they serve more of burgers and pizzas rather than apples. So start there first.
Thank you. Sorry, the next is the Sampath.
Now, I feel that made good progress as far as management of chronic disease once it is started, but we have not made much progress in the prevention, and this is where we have to really put our muscles into it and then see that prevention of renal disease has to be much more our focus.
Yeah, good.
This is a typical learner from a 60-year-old. During my when I was 30 years old, I wanted to take the CKD by its horns and then prove that every patient can be cured. But now I realized that it is such a Goliath that the David has a very poor role to play, and we need to prevent the chronic disease.
Dr. Sadanand?
Yeah. Firstly, I would agree with Madam that implementation is the key.
30 seconds, 40 seconds. I don't want to exceed the time.
One of the things that I want to know from the summit, last year also I was in the summit, what has been the impact of the summit last year, and how is this summit is going to impact? We need to get back these details as panelists. Have we really made that difference? So impact of the summit knowledge should be transferred to the panelists. One,
growth is happening, but as you know, it is happening slowly.
And second thing important is that what I would always want, it's my dream that we should interdisciplinary actions should be there. Means nephrologists should go to the cardiologist. They should be invited to cardiology CME symposiums or national conferences. Very important. And orthopedics should be invited because we prevent them from giving NSAIDs. They ask, what should I do if the patient is pain? So these interactions, interdisciplinary interactions have to increase. And
very important take-home message, interdisciplinary, because most of the time CKD died because of the cardiac disease, and we need a collaboration because the management of cardiac disease is different from with CKD or without CKD. Very important point.
One simple sentence, if you can give me time. We always have a conflict with cardiologists. They want the right hand to be used for angiography, and we want to prevent the left hand for fistula. They prick the left hand for fistula, we don't get a good quality fistula. We don't get a good quality fistula, we don't get good dialysis.
Right, you are absolutely correct. Dr. Arun, 30 seconds, because we took it at 5 minutes past 1. So we have still few minutes left. you
Yes.
know. So yeah.
Yes, sir. Because looking at the prevention of CKD, the primary role, because we've got a vast network of primary health centers, at least in our state, the process should begin at the primary level, and there should be more education of the non-medical. I mean, the non-physician people also should be involved in terms of kidney disease, kidney care. Awareness should be higher among them, and whenever they are doing these screenings, the urine routine is such a simple test that is available in every PHC. So with the urine routine, the nephrologist can do wonders. So once you have a screening system in place, and as Madam is telling, the hub spoke, they can all report to their respective hubs. They can detect whichever primary health center that particular comorbid patient is attending for his diabetes and hypertension medicine. He can be counseled to get consult with the nephrologist. So it is a channelized activity, and that channelized activity goes hand in hand. So promote this is what I would like to say.
Yeah. So
Yes.
implementation, collaboration, training of technicians, these are the keywords which has come up. Of course, prevention, as Sampath emphasized repeatedly. Another important thing is that removing the myths. When a patient becomes, develops end-stage kidney disease, no more can be managed with conservative treatment. We ask them to undergo a start dialysis. First thing they ask that, no. Once we start dialysis, it has to be lifelong, so I'll not do it. As if there's a problem in the machine that once you start, it has to be continued. The problem is in the machine. We need to remove the myths that it is not the problem of the myths, it is the problem that the kidney is no more functioning. So it needs to have a replacement treatment. There are several myths are associated with the management of CKD, prevention of CKD. Those myths needs to be removed with proper health education, and they should preferably be started at the earliest stage from the school or office and beyond. So if the panelists have no more comments to make, I will end the session, and I will thank all the members of the panelists sincerely for their very, very appropriate suggestions and comments. I hand over the mic to the organizer.
One last comment, Dr. Saha, if you permit me. See, India is a unique
You are
country.
always permitted to give the last comment.
Okay. So India is a unique country where we have this hub and spoke model. You have dialysis centers in each district of India. Which other country has it? Nobody. Utilize these dialysis centers as hub centers for kidney disease prevention, screening, training, education. Use hub and spoke model for everything, not only for dialysis, for prevention.
So collaboration and training are the two key words, I would say, which has emerged for the overall implementation aspect. We need to train people, not necessarily always the nephrologists, but the paramedical staffs, and we need to have a good collaboration. Thank you very much. I hand over to our
Thank you, Dr. Tarun, and thank you to all the panelists for their esteemed views. And I'm sure prevention is the way forward. But moving on to our next session, which is innovations and newer treatment modalities for effective
recording in
CKD
progress.
management. So let me take this opportunity to introduce the experts for this session, wherein we'll be discussing about the latest advancements in CKD management, novel treatment options, various aspects of kidney transplant, risk factors. And to discuss about these very pertinent issues, I have with me Dr. Siddhini Vishwanath, HOD and consultant nephrologist at Manipal Hospitals, Bangalore. Welcome to the discussion, sir.
Yeah.
We also have with us Dr. Arpita Roy Chaudhary, Professor, Department of Nephrology, IPG, ME and R, SSKM, Kolkata. Welcome, ma'am. Welcome to the discussion. Next, we have Dr. Sheetal Lingare, HOD, Nephrology, RJ Hospital, Goa. Welcome to the discussion, sir. And we are also joined by Dr. Lalit K. Agarwal, who's the Senior Nephrologist at Woodlands Multi-Speciality Hospital, Kolkata. On behalf of the Integrated
everybody,
Council, I welcome all of you. Yes, ma'am.
Yes, namaskar to everybody.
Thanks
and very
for
good
joining.
afternoon to all.
Good afternoon.
Thanks for joining us today. So I would first of all come to Dr. Siddhini Vishwanath. When we talk about latest advancements in chronic kidney diseases management, which particularly focus on novel treatment options or technologies. So what, according to you, are some of the treatment modalities which have shown great results when it comes to improving patient outcomes?
Primary thing is, as our previous speaker spoke about, prevention and screening, which is very, very important rather than looking at newer things. Newer things are definitely there. Newer things will come in only if your grassroots level prevention is more implementable. And we need to look at those more carefully. And we have our time-tested drugs like ACE inhibitors and ARBs, which have made difference to our nephrology community and patients. Apart from this, we have a couple of newer medications which have come into vogue recently, like SGLT2 inhibitors, Fenrenon, and tolvaptan. Probably they are SGLT2, I would call it as blockbuster molecule, which has shown a lot of results, positive results with respect to kidney protection, with respect to heart protection, with respect to weight loss, obesity, and proteinuria reduction. So these are probably newer medications which have come a long way in preventing further kidney damage, apart from the grassroots level, what I mentioned. We have a couple of newer things in with respect to dialysis, like be it peritoneal dialysis machines, cycler machines, hemodialysis machines, which have made a lot of progress with technology being implemented into that, like hemodiafiltration and special forms of dialysis which are used in ICU setting. In transplant area, apart from routine transplants, definitely in the last couple of years, incompatible transplant has become a routine, what we call as ABO incompatible transplant. We also have to look at swap transplant, because deceased donor organ transplant has not taken up to the level what we all want. So in live, how to increase the donor availability is, one is to look at swap transplants where we exchange the blood groups, and once we also have ABO incompatible transplant, where it was only a dream earlier to do transplant across blood group. Probably these are the newer things which have come in CKD management and made difference to the lives of CKDs, especially in advanced renal failures.
Right, Dr. Sidini. Coming to Dr. Arpita, when Dr. Sidini talks about, and even in the previous panel, we heard a lot about prevention, how prevention needs to be the focus instead of, at a very early stage. So when we talk about prevention, what are some of the high risk groups? And when we talk about screenings, what are the gaps that you can think of? When we talk about early prevention, screening was one aspect which every expert emphasized on. What are the gaps in screening, especially when it comes to behavior?
So actually the gap lies in touching up the whole population. We are LMIC countries with huge population. And if you look at CKD prevalence has pushed itself to a statistics of 1 in 10, both in men and women. Women are even higher, 1 in 11 almost. So prevalence is 11.4% in women and prevalence is around 10.7% in men. And huge number of, if you look at the data, you will find that nearly 200 million people of CKD, they actually live in 200 million live in all developed countries, and rest 600 million, they live in the LMICs. So huge population, number one. And then we are going through a transitional epidemiology. We have the chronic lifestyle diseases which are pushing to CKD, like hypertension, diabetes, obesity. At the same time, we have severe infections like dengue, malaria, and leptospirosis. These come in form of AKI and either worsen a stable CKD or pave the way to new CKD. Number two. Number three is lot of climate change. Lot of areas do have some environmental insult, like the Udyanam nephropathy in our country, like the Odisha belt, who also suffers from CKD-U, though their nephropathy has not been given a separate name. But we have these environmental hazards and lot of nephrotoxics in Ayurvedic and Ayush medicine. You see, whenever I open an YouTube, I find the advertisement that You don't need medications for diabetes. You don't need, and all these type of trash dialogues are being advertised on YouTube app, when these new technology inventions we cannot use to promote the exact language of healthcare from government advocacy, from NGO advocacy. We cannot put these advertisements in YouTube. That is still a gap, that we couldn't make our government feel that CKD is one of the most important expanding non-communicable disease, which is going to be the 5th leading cause of death in next few years. We are not able. That is the gap on behalf of leaders. When we leaders are sitting and exchanging our opinions, we should try in every possible way to convince our authority that what we exactly need is spillage of the prevention education to the grassroots level. See, some ASHA workers who are working for NCCD, they can be empowered with use of app, which they have done in Taiwan. People have done in Taiwan and Thailand. What they did, that these base grassroots workers are empowered through the app to collect the data from the community, to suggest where they need intervention, to collect the opinion of senior professionals to treat various diseases which go under care, not receiving proper care in the periphery. So all technological innovations that are coming up in our hand, we should try to use it in the health field for taking the more huge data, to take the suggestions that what are the care gaps, how we can improve it, to empower our baseline grassroots workers so that they can impart awareness lessons to our population. They can collect data about right hypertension control. They can collect data about good glycemic control. The small things that are required, if taken care of, they can build a strong health block.
Dr. Lahiri, very rightly you have pointed out how prevention needs to be the focus. Coming to Dr. Lalit Agarwal, when we talk about new and innovative therapies, could you shed some light on the potential risks associated with kidney transplantation and how advancements in surgical techniques or immunosuppressive protocols are addressing these concerns? You are on mute. If you could unmute yourself. Sir, you are on mute. If you could just unmute yourself. Yes.
Yeah, actually, there are a lot of innovations in the transplant technology and ultimately in the outcome of the transplant. When I see back 30 years back and now, there is a kind of sea change, what we used to do 30 years ago and what we are currently doing, and which is reflected in the results. Okay. And nowadays we have better medicines, better diagnostic and screening technology. We can identify tissue mismatches. We can find out sensitized individuals which were not there with us in the early stage of kidney transplant, say in the early 90s or early 20s. So nowadays we have better lab armamentarium in our hand where we can specify things and identify and to find out who are the high risk. And once we have identified that these are the patients who are at high risk, then we can take appropriate treatment for them so that our end result, that is the outcome or long-term survival of the patient, is better. To talk in general about the transplant outcome, there are many newer innovations. Like if we talk about the conventional transplant where a live donor of same blood group donates a kidney to the recipient, and this used to be our conventional thing in the past. And to maintain this kidney, say the half-life of the kidney or the long-term survival of these kidneys have improved along over a period of time. Earlier, we used to see a half-life of 10 years. Now we can see patients who have surviving for more than 20 years, 25 years, even 30 years. So definitely the conventional technology has improved. Apart from that, we are now routinely doing ABO incompatible transplant. Like we are doing kidney transplant across the blood group, which used to be a taboo, say 15, 20 years back. But this has become a routine practice to do ABO incompatible transplant. And this is possible because we have newer technologies, we have newer lab technology to find out who are at risk. And once we find those problems, we can solve them. Then we have people who want to do second transplant or for that reason, third or fourth transplant. Once you have a first transplant, you are likely to get sensitized. That means if you put your kidney in the recipient, the kidney may get damaged on table because of hyperacute rejection. But this can be prevented. So this kind of transplant we normally call high risk or sensitized transplant. We desensitize them and do the transplant. This is only possible because we have newer technologies in our hand, so that if patients can undergo a second or for that reason, a third kidney transplant as well. So this is a reality. We are doing that. Then we have something which is still in the experimental stage, xenotransplantation. As you all are aware that kidneys are in short supply. So the demand for kidney is more than the supply of the kidney. So the scientists are trying to find out whether a pig kidney can be humanized to be transplanted to a potential kidney recipient. So there are technologies and there are initial preclinical research which has shown, like recently this was in the news, which shows that there was a 7-day survival of the recipient who got a pig kidney in USA. So things are moving very fast in this organ transplant scenario. And then we have transplant is not the only answer. Along with transplant, you have to face many other challenges, such as infections, such as cancer. So the infection and cancer problem has also reduced significantly because we have better medicines like antivirals, antibiotics, many other prophylactic medicines to prevent infections. So overall, if you see, in general, the medical science has advanced a lot over the last 30 years, which has given us better diagnostic facilities. And with the help of these diagnostic facilities, we can do better management of these patients who have kidney failure and who wants to undergo kidney transplant. Because as we know, you are getting a kidney for a kidney and which replaces all the functions of a kidney. And the survival and long-term cost effectiveness is best with a kidney transplant. So you get, at the cheapest rate, you get the best long-term survival and you get the best quality of life after the kidney transplant. So there have been tremendous progress in this era, in this field of medicine.
Lalit, thanks for that answer. Dr. Sheetal, coming to you, Dr. Lalit talked about the gaps, challenges when we specifically talk about kidney transplant. So if you would like to take from there, and what are some of the ways by which these gaps and challenges can be mitigated to provide the best treatment outcome for patients?
So as Dr. Agrawal has already specified that there is a huge gap because the demand obviously is ever increasing. The rough figures are we have close to 2 lakh patients requiring transplants every year. And every year we are doing just around 15,000 average transplants a year. And this is a huge gap. So just around, you would say 10 to 15% of patients who actually require transplants are getting it done. And vast majority of patients are not being able to get the transplant. They are either being kept alive on dialysis, or sometimes some patients, because of the misconceptions associated with dialysis and the treatment of kidney disease, just don't receive the treatment properly. So the gap can obviously be shortened if the knowledge about benefits of kidney transplant are propagated, and the safety of kidney donation is being made more reachable. Why people don't come forth for being a live kidney donor for their family person is something which we all would like to address the problem more pertinently. So there are many myths about people not coming forth for being a kidney donor. Obviously, the most common reason is the fear of undergoing the surgery, the unknown fear about what will happen to me when I will be staying with one kidney, whether I am going to develop kidney disease in future, whether I would be able to carry my daily activities, whether I would be a patient myself after being a kidney donor. So these are all the myths which people have in their mind. And that's the reason why most of the time we see family members not coming forth to becoming a kidney donor. And we know that living donor kidney transplant has the best of results. So we would definitely want more and more people to get the proper knowledge about the safety of kidney donation. At the same time, if the gap has to be shortened, it is only going to be possible if more and more people pledge for organ donation. If you go by the number, cadaver kidney transplant or the deceased donor kidney transplant program in India is just 10 or 15% of the total number of transplants what we do. If you look at the US, if you look at Spain or Europe in general, more than 50% of the transplants there are from brain dead donors. The deceased donor transplant program is very active in Western countries. And obviously, the reasons are manifold. The knowledge, the opt-out system, what is there in Europe and US is probably one of the most important reasons. But here, obviously, the knowledge about organ donation has to be propagated. That's the only way the gap between the organ requirement and organ available is going to be shortened. So we need to work more and more as far as spreading the knowledge of being an organ donor, or at least pledging to be an organ donor is very important. So it should start right from college days, where as soon as you are eligible for a driving license, you should also be eligible and knowledgeable to be pledging as an organ donor. So if people do that, then I guess we probably may not see this huge gap which currently exists between the requirement and the availability.
Yes, thanks for that answer, Dr. Sheetal. Dr. Siddhini, coming back to you, when we talk about, a kidney transplant and the risk factors associated with that, such as infection, rejection, or complications related to immunosuppression, how do you tackle that? What are some of the things that are, ensured before we go for that?
First and foremost is educating the patient who is undergoing a kidney transplant. So he should know the importance of transplant, how important it is for him to maintain the medication schedule, not to miss any medicine, And to prevent infection, initial part, we tell them to stay away from infection, maybe a little bit of isolation in the initial part and avoid infections. In our country, it's very difficult. So they should use their judgment, try to avoid going to crowded places, try to keep away from infections. And probably most important thing is to vaccinate all these patients before undergoing transplant so that we can prevent common infections like H1N1, pneumococcal, hepatitis B. These things will definitely help. In fact, now we have the availability of Shingrix vaccine, varicella vaccine, which will help in preventing the most common infections, which can sometimes cause a lot of morbidity and even mortality in these transplant patients, because we all know most of them are already immunosuppressed. Second most important thing would be to stress upon them on the compliance issue. Many times we have seen in our practice, we may be busy, we may not know when we are done transplant, they would have gone off, they won't come even regularly. Many times we have seen people coming back after 2 years, 3 years, taking the same dose what we have prescribed a couple of years back. So immunosuppression is something is like a tightrope balance where we need to see lesser immunosuppression will cause rejection, more will cause infection. So this only the transplant physician who has done transplant will know the patient, knows how to balance the immunosuppression, and one is prevent infection. Second thing is prevent rejection. So basically we need to monitor the patient, make sure he is compliant. Most of the patients in our unit, we grill them so much that they are so obsessed with their immunosuppressive medicine. Anywhere they go, they get back to us saying, is it okay to take this medicine? Is it okay to have surgery? Is it okay to take this medicine, whether it will interact with his immunosuppressive medicine? And of course, we need to stress upon doing tacrolimus level and things like that, where we need to balance. Too much of anything is not good, so we need to balance the immunosuppression. Too little is again bad because it can trigger rejection. So this is the basic thing, and one is to importance is to make sure that the patient is compliant. More importantly, in our country, probably the caretaker is more important because they are the ones who are taking care of them. Make sure that he takes medicine on time and doesn't miss any medicines. Sometimes it may not be the issue of only cost. I have seen many patients who can afford everything, but he says simply, sir, I don't want to take so many medicines. So we need to stress upon them, which is more important, which is not important. I mean, even if he misses few medicines like calcium, B complex supplements and things like that is okay. But immunosuppression is something which he has to take only under the guidance of a nephrologist. These things have to be stressed upon to the patient and also to the family who takes care of them so that they don't miss out on these things. And probably more important in our country, as sir mentioned, we are doing more live related. So we can tell them, see, your loved one has given you an organ to you. So make sure you don't lose that organ and don't put the donor at the he should not feel guilty that he donated and then he lost the organ. So probably that may help in keeping them compliant. And there are some age groups where they are more non-compliant, like adolescents and people who are busy at work, people who are traveling. So we can probably help them to say how to keep their schedules, how not to miss medicines.
Right, Dr. Siddhini, very rightly you have pointed out that patient counseling plays a very important role. And I would come to that question afterwards, that how multidisciplinary care teams play an important role in the holistic journey of patients. Coming to Dr. Arpita, with your expert in kidney transplant, ma'am, if you could elaborate on the latest developments when it comes to donor selection criteria, organ allocation strategies that have helped to optimize, transplant outcomes and reduce wait time for patients.
So in Western countries, what I go through the literature, the deceased donor pool has now changed from the young accident victims to donors with multiple metabolic complications, because they have upgraded their road safety to such an extent that really road traffic accidents had become a minority. So where from they are getting their donors are the branded people from neuro ICUs, where usually multiple comorbidities are existing and donors become a problematic extended criteria donor. That is why probably they have come up with the guideline of acceptance of diabetic donors, which we still are afraid in doing in living donor population, and we do it in deceased donor diabetic with lot of hesitancy, looking at urine, if possible, at least looking at the light microscopy in the middle of the night, that whether the person does have nephropathy or not. So this is one new thing that that we are seeing in the world perspective, though in Indian perspective, still the whatever disease donation happens, 15% of total organ transplantation, that is coming mainly, 80% is from mainly young accident victims. Supposedly after 10 years also, we should be optimistic to elevate ourselves also that level, that our road accidents do come down to a significant. And what Dr. Bishnath had already mentioned, that I think the nitty-gritties of transplant follow-up, that how tightly you should follow up the transplant patient, how you will sensitize them. That is one very important way to improve the outcome, so that you don't get second, third transplants in a go, and already burdened system with demand supply doesn't face more problem. That is one important area. And for disease donation promotion, the number 3, organ allocation. One more thing I should highlight, that private sector people are more in deceased organ donation, deceased organ transplantation in southern and western chapter. If you look at Mumbai, if you look at Chennai, if you look at Telangana also, the key players of liver and heart and lung transplant people, they happen in the private sector. So though there is a system that private pool organ generation flows in the private donation system, the public sectors, they declare less, they don't do multi-organ transplantation, and therefore the large mass population, they are I think deprived of one benefit. So this is another important thing which government should think, that how government can build up collaboration with private sector in terms of recruiting competence in the government system, so that we can also get very good competent surgeons in the middle of the night to get the transplants done. I think that part is lacking in most government sector hospitals in our country. I would like to ask my southern colleagues that what do they feel? Where Dr. Vishnath particularly, where deceased organ donation is quite occurs in quite large volume in Tamil Nadu. Or
yes, ma'am. In fact, if you look at overall deceased organ, Karnataka is number 2. Number 1 is Telangana. Of course, Telangana and Gujarat are together. One is probably most important is educating people. In fact, people should come forward, and then they need to. Problem for nephrologist is you can't go and tell patients you donate organ, because it will be conflict of interest. So it has to be coming from the general public. It has to be coming from the people who are at grassroots levels, basically general physicians, critical care, where they need to tell the families these options are there. Otherwise, it will never happen. In fact, we had a program of felicitating first cadaver donor we did in Karnataka, which was done in Manipal 25 years ago. The parents were called. Parents felt so happy that though in that moment they took that decision, which was very tough, now they feel so happy and they were thankful that doctors gave them this option. Many times people may not give the option. So unless they know something like this is available, people may not come forward. So basically educating the general public, Probably media may be having a bigger say in this. And once it happens, it's a chain. Once one thing happens, the next patient will tell, can my relative donate like what happened last week? So it keeps on going. If it doesn't happen, it will never take off.
Dr. Vishnath, on the other hand, I would like to, what we are considering mass education is deficient. Actually, I felt that there is a lot of deficiency in our fraternity education. Our
Yes.
fraternity also is not very much motivated for considering deceased organ donation. And I think critical care physicians, they should
Yeah.
be given the
More
maximum
proactive.
responsibility, legal
Yes, sir.
protection, and
Yes,
all
sir.
sorts of support, so
Yes.
that they don't remain afraid to declare brain death. Brain death donation, brain death declaration increases, family counseling increases, and I think if there are superstition in our fellow colleagues' minds also, that probably deceased donation is not going to give results as good as live donation. And there is a whispering campaign that goes on in Kolkata, I feel, that no, deceased donation is not good. So sort of among the CKD population, among their families, whenever I offer to get them enrolled for deceased kidney transplantation, then they say that they would try to look into their distant family members, whether they can get from that. And I know they are going to get into the bad nexus, which may give them trouble and the cost the patient's life as well because of delay.
Dr. Arpita. Those myths, very rightly, you and Dr. Vishwanath have pointed out how those, patient education, mass education is important, and those myths surrounding organ transplant have to be busted. Coming to you, Dr. Lalit Agarwal, when we talk about managing, and balancing between CKT progression and minimizing adverse effects of treatment, particularly in patients with other multiple comorbidities or complex medical histories, how is that ensured?
You mean to say how do we transplant a patients who have multiple comorbidities?
Yeah, what are the concerns that are there? Not even only transplant, but the whole journey of their CKD management.
Okay. Basically, as you know, CKD is chronic kidney disease. You have kidney damage for more than 3 months. That is CKD. And there are reasons for CKD. And the most common reason is diabetes, high blood pressure. 80% of our patient population do suffer from diabetes or high blood pressure. Apart from that, we have nephritic illness like chronic glomerulonephritis because of various reasons. This can be primary, this can be secondary. Then we have hereditary diseases. Then we have stone diseases. Then we have infections. And then then various other drugs and other things, AKI going into CKD, there are various other regions. So basically, kidney is a kind of innocent bystander. So a person having diabetes, the kidney gets damaged, the eyes gets damaged, the nerves get damaged, the heart get damaged. So when the patients develop kidney failure, they also develop other organ damage also. So if we have 1 in 10 patients who have developed CKD, we may have 1 in 1,000 patients who are on dialysis. So what happens to the rest of these patients? They die because of the comorbidities in their journey from stage 1 to dialysis stage or when they require an organ transplant. So talking about diabetes, they are difficult patients. As you know, diabetes increases risk to multiple fold. So even if in a normal person who has no diabetes, and if you talk about a person who has diabetes, so definitely a person with diabetes will have high risk. So along with that, if you have diabetes related heart disease, diabetes related nerve damage, diabetes related other organ damage, definitely the success is less. Still, we have like patients, most of our kidney patients do have multiple comorbidities, except the young patients who have kind of nephritic illness, who have one organ damage, whereas most of our patients who need organ transplant, they have multiple organ damage. So definitely they are the challenges. Sometimes, when we do the surgical things, when we anastomose, if you don't have a good blood vessels to anastomose, then you have difficulty in anastomosing. So these are the difficult cases. And sometimes, we have problems giving them anesthesia. They are high risk. They have cardiac problem. Their heart functions only 20% or 25%. So these are the challenges we face on a day-to-day basis. So these are the things, you wanted to know. I mean,
that need to be taken care of. Yes, Dr. Lalit. Dr. Sheetal, coming to you, when we talk about multidisciplinary care teams, what role do they play in providing life? Dr. Lalit talked about how cardiologists, heart problems are there. Then, of course, you need to come together as a team for that better health outcome. So what role does that multidisciplinary approach play?
Yeah, so as Dr. Agrawal has mentioned, chronic kidney disease doesn't mean that you are supposed to be looking at the kidney disease and kidney problems. Most of our patients with chronic kidney disease are at extremely high risk of getting cardiovascular events. In fact, we say that patients who reach the stage of dialysis are lucky that they have not had any event earlier. So that high is the risk factor. Almost 20 to 25 times more is the risk factor of getting a cardiac event in someone who has got chronic kidney disease. And it is not just that your risk factor is high when the creatinine level is elevated. Even when a person with diabetes has some amount of albumin in the urine, that itself is a stage where the risk for heart disease and stroke gets elevated. So we have to have multidisciplinary approach and prevention right from the beginning in the phase of chronic kidney disease. So you need to have people checked their, especially diabetes, people with risk factor for chronic kidney disease, hypertension, people above the age of 65, people who already have heart diseases, people with family history of kidney diseases. So when you know these risk factors, you can make sure that you screen them for kidney disease. And when you identify chronic kidney disease at the early stage, then you can look at the interventions which can be done. First is to prevent the progression of kidney disease, and second is to prevent them from having any adverse cardiac or stroke and other outcomes. So we make sure that the patient is seen by the cardiologist if the risk factors are high. They are given medications to lower their cholesterol levels. They are given medications to get their blood pressure well controlled. So something like below 130/80 is what we recommend most of our patients. Their diabetes has to be strictly controlled. We make sure that the HbA1c is below 7%. You can have a diabetologist or a nutritionist pitching in to get control of that. If the risk factors are there, then we make sure that the patient is prescribed a blood thinner tablet like an aspirin so that heart diseases and strokes can be prevented. We also make sure that we look at their foot and examine the foot arteries so that we prevent peripheral vascular disease. One of the most common problem in diabetics and kidney disease is developing gangrenes of the foot and toe. And if you examine their foot on a regular basis, you are definitely going to make sure that you catch the peripheral vascular disease early. So obviously you are going to look as a wholesome to the patient and not just be concentrating on the creatinine when you are dealing a patient with chronic kidney disease.
Well, that was an insightful answer, and I can see the other experts joining for the next session. But before we part, I would just want to take some major takeaways coming to Dr. Vishwanath, who very rightly pointed out that awareness is important. So, Dr. Vishwanath, 5 steps through which mass awareness can be created. If you could give us 5 pointers on that, how can we ensure that level of awareness is there among the population?
Number one is basically increasing the awareness that kidney diseases do occur. It occurs in younger people. So screening is most important at a basic grassroots level. As my previous panelist talk about sugar control, hypertension detection earlier, look for proteinuria and kidney function so that you detect them early and prevent further progression. And second most important thing is probably lifestyle modification and exercise to keep yourself fit, which our Prime Minister has been promoting so actively. So we should probably look at him as a role model. You see him; he's 74 years. He is working 18 hours a day. So he is up in the sky, down inside the scuba diving. So we should probably take a leaf out of him as a fitness figure. So we should probably educate our youngsters to keep fit, lifestyle modification, stay away from junk food, no smoking. In fact, we see nowadays many women smoking, which has significant impact on both pregnancy. They cannot get pregnant. So this lifestyle modification, which is most important, and definitely seek out help if whenever you have any problem. And the most important, as Arpita madam said, organ donation and awareness, which has to be done at not only general public. We have to educate our own fraternity to say who is fit to donate, who can donate, and where they can step in and educate people to come forward for organ donation and give light to others' life.
Right. Thank you, Dr. Vishwanath. Dr. Arpita, if you could just give us 5 lifestyle interventions. Dr. Vishwanath talked about moving to a fitter lifestyle, of course, yoga. What are your 5 tips for those lifestyle interventions which can help in, a healthier body and mind?
Yeah. Before I come to this lifestyle intervention, I feel that I would take up one angle of your previous question to Dr. Shital, that is CKM, the Conservative Kidney Care Management with multiple collaborative strategies. See, we are LMICs. We cannot address all our patients, particularly the growing geriatric population whose lifespan is increased. They will not all be eligible for transplant or dialysis. So this is also a very important training that I would like to. Just a minute, I will finish the talk and I'll talk. So I would like to put it in a way that those patients who even are terminally ill, they're requiring dialysis, but we not in a right stage to take dialysis. Transplant is far-fetched. So these population, how the kidney doctor, the cardiology doctor, the general symptom management, symptom burden of CKD management, we should be taught in the conservative care of these patients by addressing the patient's problems with physiotherapies, nephrologists, cardiologists, all giving a care so that the terminal days are not the patient doesn't feel that the terminal days are too bad and they are brought to dialysis, they're subjected to some other big surgeries or like that. So that is one angle. And if you tell me that what lifestyle intervention do we need most is untagging ourselves from this mobile dependent sedentary lifestyle. Be it a kid, a young child, you know that young age adolescents had gone into a domain of very, very big pathophysiologic area for bad diabetes, bad obesity. Young adolescent people are getting obese. They, but particularly this COVID situation everywhere brought into picture the Swiggy Zomatos, tag to mobile, order Swiggy Zomato, and get into a very, very unhealthy diet style. There is a overlapping epidemiology in our country. Some people don't get adequate nutrition and some people are overnourished or badly nourished by this way, and both progressing to CKD. both progressing to CKD. So lifestyle interventions should speak about to the parents, how they would rear up their adolescent children, how they would promote exercise, playing. In our childhood, I used to see my brother comes back from the school, throws the bag and rushes to the field to join his friends where they will play. Now the situation is absolutely reversed. They would go to join some cricket teaching club where their mind and physique are not coupled with. So promoting from the very beginning, and the youngers, the young generation and anti-obese, they should remain and on more traditional diets rather than and avoiding the nephrotoxins like very high protein foods in the gym. If you promote exercise, they go to gym, they take very high protein, comes with API. And also the binge meat eating, that should be discouraged and all. So I think, and they should be made conscious about the climate change that is occurring and predisposing us to future problems.
Right.
So I
Dr.
think
Lalit, yeah, that was a very insightful answer, Dr. Arpita. Dr. Lalit, coming to you, what would be your takeaway for the day?
My take on the same thing. I mean, basically, India is a big country and it's a heterogeneous company, heterogeneous population. We have super rich, we have super poor. So, general advice is not good for all the population. I think we have to see whether we are talking to the poor patients or we are talking to the rich patient. So, we have all the different varieties of people. So we have to individualize. So if we are talking our advice to a poor patient who is financially not sound, and one we are talking with a super rich person, it should be completely different. But the generalization is avoid obesity, do exercise, eat healthy, balanced diet, do exercise, avoid alcohol, avoid smoking, and avoid over-the-counter drugs.
Drugs, yes, that is an
Over-the-counter medicines. Many times, we come across patients who take over-the-counter NSAID for quick relief, and ultimately they land up in CKD.
Yeah.
And if you are high risk, like if you are diabetic, hypertensive, elderly people, or a family history of diabetes or high blood pressure or kidney disease, you should undergo screening on a regular basis to identify disease at the early stage so that you get the best benefit on treatment.
Thank you, Dr. Lalit. Coming to Dr. Sheetal, what would be your major takeaway for today's session? If you could quickly sum it up so that we can move on to the next session.
I guess what we want to tell everyone is kidney disease or chronic kidney disease is common. It is harmful, but it is preventable. And there are very simple steps which the previous speakers have highlighted as to how one can take care of his kidneys. So there is no rocket science, but just simple measures. If you stay yourself healthy, obviously you can definitely prevent most of the kidney diseases which you are going to face, especially if you are at high risk with diabetes, with hypertension, with family members having kidney disease, or if you are someone who is taking some painkiller medications on a regular basis, someone with previous history of kidney stones, or people with heart diseases. If you have any of these risk factors, then do get yourself tested for kidney disease and ask your doctor. I mean, you can definitely ask your family doctor, your physician, and ask them to test for kidney function. That is very important because many a times not testing is one of the reasons why people land into late stages of kidney disease. So I would say test early and be safe.
Dr. Sheetal, Dr. Lalit, Dr. Vishwanath, ma'am, thank you everyone for joining the session and taking out time from your busy schedule. Thanks for being there. With this, we move to the last session of our Kidney Care Summit, which is kidney stones, a major risk factor for CKD. So the session will comprehensively cover discussions on increased risk of CKD among patients with kidney stones, as well as strategies for early detection and prevention. The deliberations will also cover approaches to effectively manage and mitigate the risk of CKD in patients with kidney stones, ultimately improving patient outcomes and kidney health. So let me take this opportunity to introduce the guests that I have for this session. For this session, I have with me Dr. Sharat Seth, who's the consultant and head nephrology surgeon, Kokilaben Dhirubhai Ammani Hospital, Mumbai. Welcome to the discussion, sir.
Thank you.
Next, I am joined by Dr. Manish Singla, Chief Urologist, RJ Hospital, New Delhi. Welcome to the discussion, sir. I also have with me Dr. Puneet Bansal, Chief Urologist, RJ Hospital, Ludhiana. Welcome to the discussion. And I have with me Dr. Sandeep Nonia, Urologist, EHCC, Eternal Hospital, Jaipur. Welcome to the discussion, sir. I can also see Dr. G. Gokul Nachiket, who's the consultant urologist, andrologist, and renal transplant surgeon and laparoscopic surgeon at Medicover Hospitals, Nellore. I welcome all our array of experts today before we delve into the importance of how kidney stone is a major risk factor for kidney diseases. Welcome to the discussion to all the experts. So coming to you, Dr. Sharat, first of all, when we talk about the significant risk factors for the development of chronic kidney disease in patients with kidney stones, how do these factors influence treatment decisions and long-term management strategies?
Well, I welcome all my Euro colleagues for this panel. I being the sole nephrologist. I think this is more pertaining to urologists, so I'll make them talk more. We all know that the lifetime risk is 5% in females and around 12 to 13% lifetime risk of stone in one's life. It's not a small figure. And eventually, the progression of CKD to end-stage renal disease in stone patients is about 2.5 to 3%. So it's not a small, it's a sizable number of them. And most important is it is preventable. So having all the urologists on board, having treated these patients appropriately should prevent further progression to end-stage renal disease. And we also know that 10% of these calcium oxalate and phosphate stones recur in 10 years, in 50% of cases. So recurrence also should be subjected to appropriate investigations and the modality of treatment. Now, gone are those days where we had to do open surgeries. Now we have multiple laparoscopic, robotic surgeries at hand. So these particular stone disease, it's unfortunate if a person ends up with end-stage renal disease as a result of calculus stone, which is very much preventable.
Sharat, thanks for that answer. Dr. Manish, coming to you, because when we talk about the journey, the treatment plan, one size fits all approach is no longer working. So when we talk about, key components of a comprehensive management plan about somebody with kidney stones and he is progressing towards chronic kidney diseases, what are some of the criteria when you keep in mind while tailoring or personalizing their plans?
Thank you, Dr. Moini, for giving me this opportunity and having me here. So before I answer your question regarding CKD in kidney stones and management, let me tell you there are recent population studies which have shown that kidney stones are a major risk factor for CKD. In some of the studies, it has been mentioned that the symptomatic kidney stones are responsible for around 10 to 11% of CKD patients. So it's a huge number, as Dr. Sharat mentioned, and it progresses to end-stage renal disease in 2 to 3% of patients who are requiring hemodialysis or transplant. So let me tell you, before I talk about management, what are the reasons why kidney stones patients develop CKD? So there are two major reasons and there are 4 or 5 minor reasons. Two major reasons are the obstruction by the stones to the kidneys, leading to the acute renal injury and ultimately to the CKD. And the second most common reason is the recurrent infections in the urinary tract in the kidney, in the sense that recurrent pyelonephritis leading to the CKD. These are the two major reasons for development of CKD in kidney stones. The other reasons are sometimes the type of stone is responsible for the renal failure or CKD. Type of stones, if we talk about, the major reason is the screw-white stones. Screw-white stones it's a combination of large stone plus infection in the kidney. So as I mentioned, the obstruction and the infection are the two major reasons, and screw-white stones develop out of infection and leads to the obstruction and hence the CKD. So other type of stones, if we talk about the uric acid stones, they are responsible for CKD in the sense that CKD, that's uric acid stone patients have hyperuricemia. So hyperuricemia itself leads to the renal injury or renal failure. So there are other less common kidney stones. Those are called hereditary kidney stones, which are present in the children or younger population. Those are, although they are less common incidence wise, but those are the cystine stones. Those are the stones develop out of primer hyperoxaluria. So calcium phosphate stones, bruchite stones, these stones, the type of stones also leads to the CKD. Then there are many patients who develop symptoms out of kidney stones and they take multiple drugs, nephrotoxic drugs, which leads to the CKD. Now, the other common reason is that CKD and stones have some common risk factors. The common risk factors means less intake of water, poor lifestyle. So those are the common risk factors which lead to the kidney stones as well as to the CKD. So these are the major reasons for development of CKD in kidney stone patients. So as I mentioned, so if we talk about the management and treatment part, so we, in the case of obstruction and infection, we must treat the obstruction. We take out the stone as quickly as possible. And we need to take care of the recurrent infections. Even after stone removal, some patients have recurrent infections or pyelonephritis. So we need to take care of those infections as well. We need to teach the patients that we need to tell the patients that the stones are recurrent stones. It's not that once you're treated for stones that it will never come again. So you have to stick on your diet, on your follow-up. So you should avoid taking nephrotoxic drugs. These are the major ways we can treat the patients with the CKD.
Right,
And
Dr.
kidney
Manish,
stone.
I'll come to the diet and other preventive aspects in the later part of the discussion. Coming to Dr. Sandeep, when we talk about, like Dr. Manish also pointed out, that there are certain misconceptions and myths that are related with kidney stones. People are like, no, you don't need a surgery. If you go for a surgery, the stones will come back. These are some of the myths that people believe in when it comes to kidney stones. So in your practice, what are some of the misconceptions that you have heard and tried to, promote informed decision making amongst your patients, amongst your group of patients? Yeah, you are on mute, sir. No, you are not audible. If you could just increase the volume there. I think you need to unmute yourself. Dr. Sandeep, you are not audible. I think there is some technical issue.
I think he needs to rejoin.
Maybe Dr. Sandeep, you can leave and rejoin again if we could have your voice then. Meanwhile, I'll go to Dr. Puneet Bansal. When we talk about kidney stones as a major risk factors. What are because Dr. Manish touched upon the lifestyle interventions, which can go a long way in ensuring
Am I audible, ma'am?
populations? Yes, I think you're
Yes.
audible now.
Okay, Dr. Sandeep, am I audible?
Yes, you are audible.
Okay, okay.
So we'll come to you, Dr. Puneet, in the
Okay.
later part of the conversation.
First of all, I would like to thank Moini ma'am for giving me this opportunity. Since stone disease is very much prevalent in Rajasthan, I belong to Jaipur, Rajasthan. So stone is very rampant and very common disease in Rajasthan. So when the bulk of the disease is high, definitely there are some misconceptions which is prevailing in the society. The most common misconceptions are that, first of all, there is a strong belief that beer consumptions can help in spontaneous expulsion of stones. So many times, a lot of youngsters indulge in some alcoholic activities. And although I strongly differ them, that beer only increases the diuresis. So other flavored fluids like plenty of milk or soda or some other lemonade, they can also bring the same results. And consumptions of beer, which has a high alcohol consumptions, also reduces the pain sensation in them. So during the acute episodes of the pain, which causes the renal damage, that symptoms will also be masked by the beer. So I strongly differ that beer does not have any correlation with spontaneous expulsions. Second, there is a blanket statement regarding the size of stones which corresponds to the spontaneous expulsion. Many times, some patients have 8 to 9 mm stones which spontaneously come out from their urinary passages due to the strong peristalsis of the ureter. Later on, this became very much common dictum that so and so person has passed an 8 or 9 mm stone. So definitely we will also be benefited by the normal conservative treatment. But it is not strongly advised that 8 mm stone in some persons can be passed spontaneously. Contrary to that, in some cases, we have to operate even for 4 to 5 mm stone. It depends on how much obstructive uropathy, how much symptomatology in that patient that stone is causing. Thirdly, some 8 or 9 mm stones which are non-obstructing usually present in the kidney. Suppose Dr. Manish, as think he is joining as a urologist, so he can know a lot of patients are there where 8 or 9 mm small non-obstructing stones are found in inferior calyx. Then later on, we advise them that there is no need for active intervention since the stone is neither causing any damage nor have any symptoms. But later on, after a few weeks, that stone usually get obstruct the ureter. It fall down. And another urologist counsel that you need surgery immediately. Then you should not make any general consensus about that particular doctor has advised for conservative treatment and there is no need for surgery. Now other doctor is advising me an immediate surgery. Please leave these decisions on the consultant or on the clinicians whether this particular stone needs treatment or not. Sometimes the bulk of the stone is also which major part that which governs the treatment. A large stones like staghorn stones, which does not causes an acute symptomatology, but these stones usually produce a small subclinical infections. These patients usually behave repeated urinary tract infections, sterile pyuria, dysuria. So it is not necessary that the stone always causes a severe symptoms because many times when we advise surgery or intervention to a patient with large stones which does not cause any symptoms, they usually refrain. Doctor, neither I have any blood in the urines, neither I have any obstructions, my creatinine is also normal. So this is also a misconception that only those stones which causes a severe pain needs intervention, but it is not like that. Dr. Manish already told that major burn to the kidney is mainly two forms. First is obstructive uropathy, second is recurrent infections. Sometimes overzealous or continuous use of nephrotoxic antibiotics like amikacin, which is very prevalent in UTI in remote areas. People used to take antibiotics from some peripheral doctors. Almost 2 to 3 weeks of the aminoglycosides they are consuming to eradicate UTI. So although the stone does not cause damage, but these overzealous use of antibiotics can lead to the renal damage. So blanket treatment should not be taken from the normal doctors. You should always contact some specific doctors which know the consequences of the stones. And these are some misconceptions: the size of the stones, symptomatology of the stones.
Right, Dr. Yeah, thanks for that answer. Dr. Puneet, coming to you, like I asked you about how when we talk about stones and prevention is better than cure, what was the consensus for the previous session also, and Dr. Sandeep and Dr. Manish has rightly included about antibiotics, taking too much of medicines. Also, what are some other lifestyle interventions that individuals should ensure at a personal level so that they can avoid reaching that stage?
See, first of all, we should understand that stone disease is one of the most common diseases, especially in the western part of the country. And now it is increasing at a very fast rate. So we definitely need some form of people education and education to the masses that certain preventive factors should be taken. They should be always advised. I always advise my patients to have a good fluid intake. And these are the common factors. This is a common factor which along with which is a risk factor for CKD also. So that is one very important factor which can be easily followed. In fact, many of us ourselves are stone formers. So patient should be always told that once a stone former, always a stone former. And number two is the junk foods. The junk food should be avoided. Nowadays, junk foods are so prevalent with the coming up of these food delivery apps and all. The younger generation is into obesity and taking so many junk foods that causes increased stone formation. And we are seeing many nowadays in my last, I am practicing from last 15, 20 years. In last 3, 4 years, we have seen a significant increase in pediatric patients, in young boys and girls who are having stone formation. And I probably think that this is due to the increase in the junk food intake. Number three is lifestyle modification. Lifestyle modification is very important. We should be encouraging for outdoor activities. Now the children and everyone is hooked onto their phones and they have a sedentary lifestyles. They don't go out. So these are the three major factors which I feel are very important that should be told to everyone, and the masses should be educated so that they don't develop stones. And another point is what I don't know what other panelists have to say about it. I feel that patients who have stone disease, before they present to us, they have some element of CKD. Many people who have come to us, even with small stones in the kidney, they already have a slightly raised creatinine. Now, how this is related, I am not sure. But there are certain studies. I was just going through the literature today morning. I saw it is being now, it's a known fact that CKD is associated with stone disease, even if it is not causing any infection or obstruction. Once it is causing obstruction or infection, it is we all know that it will cause a chronic kidney disease. But even if the patient doesn't have a obstruction or infection, these people have some sort of CKD. Maybe they are taking painkillers for a long time. But the RMPs, in Punjab, it is very prevalent. In Punjab, patients often come to us at a last stage. They come to us when the creatinine has risen, when all local medications have failed. Probably this will be true for Rajasthan also, I'm not sure. But in Punjab, this is very rampant. Patients come to the doctor, to urologist, only when everything has been exhausted. So by that time, the damage has been done. And it is very sad to see that patients end up with CKD and ultimately going to renal replacement therapy.
Dr. Puneet, thanks for that complete overview. Coming to Dr. Gokul Nachiket, when we talk about stones, per se, in terms of CKD, Dr. Puneet also said that awareness level has to be, that awareness has to be disseminated. Especially he talked about how youngsters need to have that lifestyle modifications, not having to cut the story short. What are some of the ways by which awareness can be proliferated, and you as an expert, as a practitioner, how do you inform your patients? Are they a part of the whole decision making process? How does that go?
Thank you, Dr. Moini. Regarding the increasing the awareness regarding the management of renal stones, and because of the renal stones patients getting into the CKD or CKD patients getting into the renal stones problem. First thing, as Dr. Puneet already told, from the childhood, the modifications of the lifestyle should start. From then, already people who are in the middle age are more prone for this problem, as the previous generation has followed certain changes in their lifestyle. And now we are suffering because of that. And from the part of South India, we can tell the most common cause of the patients getting into the CKD is because of the diabetes. Diabetes is the most common cause in this part of India. Because of this, it is proning the patients into the next part of its what you say, the external stage with CKD. So these patients who are mainly having the diabetes and hypertension should be cautious in maintaining that by controlling the diabetes properly and preventing the recurrent infections in them. Because of these patients more prone for the infections, there are more chances of getting the patients into recurrent urinary tract infections, getting the patient into the renal failure. So in those patients, always we should have a proper maintenance of the diabetic status, and they should have a proper dietary lifestyle. So we can suggest those type of people to promptly monitor the status of the diabetes and the renal stones and hypertension. And if any chance of the renal stone formation or anything is there, they should address to the medical practitioner in an early stage to avoid the final complications because of that obstruction. So I may suggest dietary changes because of in this part of India, they are more prone for taking intake of the rice, and newer protocols are coming by giving it, changing with the millets type of things, so that the glycemic controls are maintained in this type of diets. So we can follow those type of things. And main thing is adequate hydration is very important to stop the stone formation. If any small stones are being formed, they will be flushed out by intake of the good amount of water. And also avoiding the intake of the protein content from the home or outside. It is always better to restrict the intake of proteins once a week rather than intake of more amount of protein as a lifestyle modification. And as I told before, we should avoid analgesic abuse, because the patients who are diabetic and renal stones at the recurrent infections and renal obstructions, they are more prone for giving analgesics for the immediate relief. Because of that, the patients are more prone for developing into the CKD in the recurrent infection protocol. So I always suggest these patients should be monitored, and they should seek their healthcare experts at an earliest stage to avoid the patients already diagnosed with these comorbidities entering into the CKD's level. That's what I can suggest.
Right. Thank you, Dr. Gokul. Dr. Sharad, are you there? I think Dr. Sharad.
Yeah, I'm there. Can you just switch on my video? I think you have.
No, okay.
The host has asked you to start your video. Start my video. Okay.
Yeah, Dr.
Yeah.
Sharad.
Yeah.
Yes. So when we talk about surgical interventions, what are your recommendations for somebody with advanced kidney disease, and how do you balance the risks and benefit of these procedures for your patients?
No, as my previous speakers rightly highlighted, that tight control of obstruction at the earliest and infection is the most important crucial part of it. And along with that, if they are diabetic or hypertensive, other comorbid conditions leading to CKD should be treated. So depending on the place where the stone is located, a urologist is the best person to take a call. And now, as I said, the open surgeries are no more done. So there are the uroscopies and ureteroscopies and lithotripsy, which is extracorporeal. We can break the stone, or we can lithotripsy by putting the video inside the urinary system. So they are relatively easier and non-invasive and patient. So those which are obstructive stones, obviously, as the previous speakers have said, need to be tackled on a priority basis, obstruction to be relieved. Otherwise, it will lead to CKD and damage to the kidney. And most of the stones also have associated infections which needs to be treated. So now we have the endoscopic modality and laparoscopic and robotic way of treating the stones.
Dr. Sharad, thank you for that answer. Coming to Dr. Manish, if we talk about the major challenges that you encounter in managing patients with kidney stones who are at an increased risk of chronic kidney disease, and how do you tailor your treatment approaches to address these challenges?
So the first challenge starts from the home of the patient. So in the sense that once the patient come to know that he or she has a stone, so there are multiple advisors at home who tell the patient that you do this, the stone will come out, you will do that, the stone will come out. The first and foremost challenge is at the home. So, so in that way, so by trying that, the patients generally lose some of the important days or weeks treating those, I mean, getting those alternative treatments. The second challenge comes, patient generally avoid going to the specialist. They generally prefer to go to a homeopath doctor. So I'm not criticizing the homeopathy here, but the fact of the matter is, there are few stones which are not amenable to any medical therapy. As we mentioned, there are stones which are causing obstruction in the kidney, large stones, which are which need surgery or some kind of intervention. So, but there are claims by some of the doctors or homeopaths that they'll treat the stones, even the large stones. The second challenge is that. The third challenge is some alternative gurus or babas or those who are giving treatment to the patients that uh, they go to their ashram. I mean, whatever they do, then there is no stone after that. So those are the major challenges. Challenges in the sense that by doing that, the patients lose important time. So if there is a obstruction for a long time or infection, there is a long time. So ultimately, the kidneys suffer. So those are the major challenges. Then then the, like I said, the patients avoid going to specialist at once. The next category comes the general physicians or family physicians. So there are lot many physicians or family physicians or those who are not well aware of the recent advances in the treatment available to the stone. So they treat their old methods, their own ways. So by doing that, people lose some time. So which is very important, as I mentioned. Then the patient come to the specialist. The challenge comes there. So if we tell them in the first go that it is a big stone and you need some kind of intervention, they generally prefer some kind of conservative management. So in by convincing the patient, some time is lost or treatment is delayed. So those are the challenges basically which we face in the sense that we lose some time.
Yeah, thanks for that answer, Dr. Manish. Coming to Dr. Sandeep, because Dr. Manish talked about how, the caregivers play a very important role in the over scheme of things. And, there are a lot of decision makers in the family at the start of the discussion itself. So, Dr. Sandeep, you feel counseling the patient, the caregiver, the family is an important aspect of the overall journey. And in your practice, how do you ensure that? On mute, sir. You are on mute again.
Okay.
Yes, you are on.
Can you repeat the questions, ma'am?
It was about how counseling plays an important role when we talk about caregiver counseling, patient counseling, because as Dr. Manish pointed out that, that caregiving starts at the basic level, aise kar lo, ye kar lo. So does counseling the patient, caregiver for long-term implications an important part of your overall treatment journey?
Yes. Okay, thank you. Definitely, the counseling plays a very important role. Those patients who have acute symptoms, either in the form of blood in the urines or have severe quality pain, counseling doesn't help them because already they have prepared their mind that we should need an interventions. The counseling mainly plays a role in those patients who have mild symptoms. Either they have repeated use of antibiotics for recurrent urinary tract infections over a period of time, or they have some microscopic RBCs in their urine blood, or they have small renal damage over the course of the times leading to slow progressions of the creatinines, because it is a very great boon to the human beings that they have two kidneys. And most of the patients think that even the one kidney has been compromised, even then the serum creatinine remains normal, the urine output remains normal, the behavior of the patient remains normal. So they think that these stones are meaningless for us. uh, Most of the surgeons have known that nowadays that the ratio of stone disease has almost gone equivalent to the nephrectomy for stone disease. Nowadays, stone and nephrectomy has become equal in ratio. Earlier, stone diseases outright the nephrectomies, but nowadays patients are so much reluctant to their stone diseases that they land up into non-functioning kidneys. And earlier, Dr. Manish also told that nowadays the general physicians keep on prescribing their medicines as far as their knowledge is concerned. And we cannot put whole blame on the patients, because over the course of the times we have seen that lot of patients are compliant to their physicians. It is their responsibility of the clinicians that in spite of prescribing medicines weekly or twice weekly, we should refer the patients, because we have seen that many patients who have recurrent urinary tract infections, ultrasound is showing 12 or 14 stone. Physician knows that this infection is due to stone diseases. So in spite of referring to the urologist for removal of the stones, they keep on prescribing the medicine. So it is our role also that we should not prescribe irrational medicines to the patients. Second part is treatment part is also important. We should also inform the patients about detailed modalities which are available nowadays, because nowadays minimal invasive interventions are very much over the counter available. So nowadays almost second tier or three tier cities are using the laser surgeries. So RIRS, URSL, mini PCNL, micro PCNLs, all these modalities are available. So these are almost just like office procedures. Within 24 hours, patient can be discharged with hardly any cut or even no cut on the body. So there is no need for refrain from their work, because many times the stone disease affect youngsters, and youngsters are under the pressures of their offices. So most of the times they think that if we underwent an surgery, we have to refrain from our office activities at least for 7 days or 10 days or 14 days. That is not possible for them. So during the counselings, we always put forward that these are certain modalities in which you can get your stone treated and you can resume your activity even after the weekend surgeries. Third part is we should also counsel them about the regular follow-up, because once a stones always be a stone formers. So we should always emphasize about the regular follow-up of the patients. We should also counsel that if one member of your family has stone disease, then other members should also be screened. Not so frequently, but at least they should be screened, because they are also at par of becoming a stone patient. So the longer follow-up, as far as the type of the stones, the stone burdens, and depending on other comorbidities, I always prefer multidisciplinary approach in a patient of the stones, because definitely most of the patients are either diabetic or hypertensive, or even after stone surgery, they become hypertensive due to some scarring in the kidney. So longer follow-up is also advised in these patients. So definitely there is a strong relation of counseling while informing to a patient about the stone disease.
Right. So counseling is an important aspect of overall treatment journey. Dr. Puneet, coming to you, when we talk about the present protocols for managing patients with kidney stones and of course chronic kidney diseases, you think there are certain gaps or areas which can be improved? What is your take on that? How can we improve those current guidelines and for better, treatment outcomes for the patients?
See, Dr. Manish and Dr. Sandeep has put forward a very important point, is the counseling. The problem is, before the patients come to us, they have already been negatively counseled. Patients, when they visit to a urologist, they mostly visit for the treatment. When the patient is mildly symptomatic or mild UTI or mild pain, they don't come to us. And they have been treated for a long time with their primary physicians, with their registered medical practitioners and quacks, as Manish said. So that is a major factor that compromises the treatment. Because once the patient is in consultation with a urologist, then patient will be definitely better counseled. Patient can be told about that these stones will see, stones have got only two things that will happen. One is the growth and another is migration. Nowadays, many studies have come up that even small stones are significant. The thing that small stones in the kidney be left alone, they won't do anything, they won't do any harm, that's a totally wrong concept. Now the stones will either grow, or they will cause urinary tract infection, or they will go and cause obstruction in the ureter. So once they have caused an obstruction, they will definitely have a long-term impact. And in future, these patients will develop chronic kidney diseases. So you should counsel the patient and treat early before any chronic kidney disease sets in. And any urinary tract infections are there, they should be treated. They should always be treated before you go on with surgical intervention. Next thing is multidisciplinary approach. You should always have a team with you. Another problem that we have a shortage of nephrologists in our country. Nephrologists, most of us, we don't have access to the nephrologists, and we have to deal with the patients ourselves. So we need a proper counseling of the patient, that you need to consult to a urologist and a nephrologist and proper multidisciplinary treatment. Another point is follow-up. Once a stone former, always a stone former. Patients, I always tell my patients that you should come to me every 3 to 4 months, get your renal. I don't get only ultrasound. You should always get your renal functions every 3 months or 6 months and know whether your creatinine is rising. In that way, we can have a better prognosis and less number of patients who would ultimately land with chronic kidney diseases. Regarding the management, nowadays we have many advanced lasers and advanced machines where there is no nephron loss. We can just go through the ureter and break the kidney stones. So we need not do a kidney loss. Without nephron loss, we can operate on the patients. That should also be told to the general population, that there are many other options available rather than any open surgery. Still, Dr. Sharad said that open surgery is almost obsolete, but actually it is not. Actually, it is not. You go to the periphery of Punjab, and there are n number of patients who are still undergoing nephrolithotomies and pyelolithotomies and open surgeries, which have got no role in modern day medicine.
Dr. Puneet. Coming to Dr. Gokul Nachiket, if I could ask him about the unique challenges in diagnosing and managing patients with existing renal impairment. How does that work?
Coming to the challenges in diagnosing that what you are putting forward. So the patients, many of the patients in our society are silent CKDs. What we are seeing is people will end up in falling the healthcare hands at the final stage, when the CKD stage is in the final stage and they are having the breathlessness and they're having the swollen limbs and they're having the different form of the final stage of CKD, then only they are able to diagnose that they are having the CKD. This is a very wrong thing in this type of society, where the healthcare sector is in a way far ahead comparing to the different countries. The problem coming here is early diagnosing is missed because of a false thing, which in our minds, everything is all right. One thing which is problematic is we are having the two kidneys. Even one kidney is getting totally zero function, the other kidney is compensating, and we are able to move life forward. And whenever that is suffering, we are able to find the problem. And at that point of time, it is difficult for the treatment, for the individual, for the caregiver, and also for the family. So for this point, it is very important for a patient who is having the, as I told before, the patient who are having the associated comorbidities, even they are getting into the stage of CKD, early CKD, they should have a conditional every tri-monthly checkup for the kidney, how it is functioning. And also we should have regular scans in the patients who are already treated for the urinary stones, because once already people have told that once a stone former is always a stone former. There is a formation of the risk is always there. So those patients should be in the regular follow-up, ideally in the hands of the nephrologist or urologist, so that if any small thing is getting into a change, we can easily identify and treat them early, so that the lifespan getting into the final stage of CKD will be prolonged. So that this is very important part, which we should be addressing and concentrating, because silent CKD is very much prone in our society. If a cross-sectional study, if we do, mostly many of the diabetics will be having a serum creatinine above more than 2, and they will be carrying in that stage up to 5 to 6 years. And in those times, these people will be used and given multiple nephrotoxic drugs, and they will directly land up into the final stage of CKDs. So the patients who are having comorbidities should always in the follow-up for the urinary tract infections, regular checkups for the stone formations, and avoiding UTIs, so that these patients can be having a good lifestyle in the course of time. That's what I can suggest.
Dr. Gokul, thank you for that insight. And I can see time running, but I would not leave all our experts without having one major takeaway about today's discussion. So I would come to Dr. Sharath first. What would be your major takeaway for our audience? You are on mute, sir. Yes.
I'm very thankful to all my neurosurgeon colleagues for having so much consideration to a nephrologist that patients should not progress to progressive CKD and end-stage renal disease. And just to sum up, beer probably has no role to play. Homeopathy drug probably has no role to play. And it is advisable always to see the proper consultant, especially a urologist, along with a nephrologist, so that the associated conditions a nephrologist would take care, and the intervention is done by the urologist. So associated diabetes infection jointly to be treated, and painkillers, non-steroid and inflammatory drugs to be avoided. And again, we said that the interventional modalities have changed now. So the treatment of stones is far more easier, and it should less time consuming, and it should be advocated that these patients should resort to this treatment before, as Dr. Sandeep said, they end up with a kidney failure and eventually nephrectomy. That should not happen. So this kind of education is required.
Right, Dr. Sharath. Thank you for that insight. Dr. Manish, coming to you, what would be your major takeaway after today's discussion? You are on mute, sir. If you could just unmute yourself. Yes, thank you.
So my take is that I want to say something about the myths and facts about the kidney stone. So as our co-panelists have spoken about it, that beer is a big myth, that beer causes the flushing of the stone. But in fact, it causes more number of stones, in the sense that it causes dehydration, and the calcium oxalate stone formation increases. This is the first big myth. Second big myth is that you should avoid taking fruits and vegetables containing seeds. It is another myth. It's nothing like that. If you avoid guava, lady fingers, and brinjal, that you will not have stones. This is another big myth. The third myth is that if you take barley water, that you'll not have stones, or your existing stone will be flushed out. But my take on this is that barley water is as good as a simple water. If you take 2 glasses of water, it is as good as your barley water. Then again, it's a big myth that if you take 4 to 5 liters of water, you'll not have stones, or there are less chances of stone. But in fact, in some number of patients, especially in elderly, if you take 4 to 5 liters of water, you will start having some urinary symptoms because of enlarged prostate or some heart conditions and all. So they will end up, they will they will be in trouble, and they'll again visit to a urologist, but for a different reason. And another myth is that there are few medicines which can dissolve the stone in Ayurveda or homeopathy. And my take on this is that there is no medication in any of the pathy who can dissolve the stone, except their exception is only the cystine stones, where some medications can work, but the incidence is very, very low for cystine stones. And another myth is, if you avoid taking calcium, which is required in few medical conditions, you will not have stones, or if you take calcium, you will have increased chances of stone. So my take on this, that if you take calcium or calcium rich food in moderate amount, you'll not have increased incidence of stone.
Thank you for that answer, Dr. Manish. Dr. Sandeep, coming to you, what would be your major takeaway from today's discussion?
I think a lot of things has already been discussed. But one thing I would like to add, that a patient should always consider a doctor or clinicians, either with the help of the patient or without the help of the patient, a multidisciplinary approach should be taken. If a patient is diabetic, hypertensive, or CKD, we should always consult to the respective doctors, along with focusing on our single specialty. Second thing is, if apart from the CKD or hypertension or diabetic, I have never seen any disease which needs a prolonged treatment. So this is mainly for the patient perspective. Some patients are very much compliant to some specific family doctors. They have 1 or 2 or 3 years of the treatment with the clean-cut evidence of a disease. For example, a patient is having a small subcentimetric stone in the kidney and he is taking treatment for recurrent UTI for the last 1 year. They should consult to some other doctor with very low threshold, in spite of switching or adhering to same doctor for a pretty long duration of the time. Thirdly, we should not take advice from our other illiterate peoples. And we should not make some blanket interpretation from the society that such a stone can be passed easily, such a stone can be managed. We should not take advice from the quacks. These are easy exit strategies, because although most of the people, these quacks, it is not important that we are illiterate and then only we go to quacks. I have also seen most of the educated patients who are also coming in the shelter of the quacks, because they want some easy exit strategy, because they want, once a patient comes to the surgeon, if as a surgeon we directly counsel him for the surgery, he always go to some other nephrologist, just in hope of that he will say that no, you don't need surgery at particular point of the time. So easy exit strategy should be condemned. If a specific doctor has informed you about some modality, you should go and follow him. This is my advice.
Thank you, Dr. Sandeep. Dr. Puneet, if you could quickly give us a major takeaway from today's discussion, something for our audience.
I think more or less my colleagues have discussed about it. I would just like to put in a few points. One is mass education program. People have to be told, the public has to be told that kidney is as important as the heart. Still, we have a very good information about the cardiac disease. People run to cardiologists when they have any cardiac problem, but they don't do the same for the kidney diseases and the urinary stones. So they should be counseled. Number 2 is your treatment modalities. the treatment modalities should be told to every person, to every practicing physician and doctors, that there are many treatment modalities that are available, which can be easily treatable, which are easily treated, and you need not have the work loss. And number three is you should have always you should consult a urologist whenever you have any problem, rather than consulting any non-qualified practitioner. So these are my takeaways about the food myths. I think my panelists have already discussed about that. That should also be and lifestyle modification. I already told that.
Right. Thank you, Dr. Punil. Dr. Gokul, Nachiket, if you could just sum up the conversation as a major takeaway for us.
Already I have my colleagues have explained the takeaways, and I want to tell 2 points. Important thing is, first we need to educate the patients and the mass that CKD is a very bad disease that everybody should know. One, if anybody have a suggestion that through which way you have to end your life, it is always not through a CKD, because it is such a type of disease which will ruin your life, and not only your life, not the total family also will be ruined because of that disease. So this should be entering into the minds of the masses, and they should be constantly motivated for avoiding those things to getting into that type of disease. Another thing is, always we should have a multidisciplinary approach. Always a nephrologist and urologist should be in a good terms, and a patient will be managed very quickly and very tactically if they both are in the same levels of terms. So always I will suggest that team approach is very important in managing a patient, either urinary stones or kidney stones or a CKD, whatever it is. A team approach is very much important, and we should always go to that point. These are the 2 things which I will end in this.
Thank you, Dr. Nachiket. On that note of having a team approach, I would call it a day. And thanks to all our experts for joining us for this insightful discussion on the eve of World Kidney Day. And I'm sure our audience will today take up a lot of relevant information from our experts. And thank you for being with us.
Thank you very much, Dr. Moini.
Thank you, sir. Thank you. So that is all for
today,
everyone. Keep on following our social media pages for more updated information on health and well-being. Take care, stay healthy, stay happy.
Thank you.
Thank you, sir.